We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 8 of the Benchmark Menopause. So it's my privilege to introduce the convener of today's webinar, Dr. Monica Ma'am. Ma'am is a consultant obstetrician and gynecologist at
Heidi,
Mangalalaya.
let's begin. It's already 6. I am the coordinator for the program, convener Dr. Ambuja Madam. Let me introduce the benchmark series by Dr. Sneha Buyar Madam. First webinar series on each topic, and they are truly benchmarks in themselves because we will be discussing all the aspects of the particular subject. So today we are at the 8th episode of the series, the menopause, and our convener for today, Dr. Ambuja Madam, has taken a lot of efforts to put the entire scientific program together. Madam has been the president of the Indian Menopause Society in the year 21 to 22. She is.
But Monica, this much is enough because we'll proceed with all the.
Sure, ma'am. I request you to please give the preamble and the inauguration.
Yeah. Thank you, Monica.
Yes,
and
thank you.
It's my proud privilege to start the program. And we'll start the program with the Ganesh Vandan. Good evening, everybody. I welcome you all for this webinar, which is going to be very interesting. And I really thank Dr. Jaideep for accepting to be chief guest of today's program. All of you know that she is a highly learned person and accomplished, I can say, both academically and on to the her own family side also. Jaideep, you are a benchmark, I can say. We all will follow, we'll try to imitate you also in so many things. So you are welcome, Jaideep. And all the guest of honors, Dr. Hara Patnaik, Dr. Jignesh, Dr. Sudha Sharma, they're all very closely associated with me. Even in Jignesh time, it's not 1 year presidentship. I can say that I did 2 years presidentship. I was so much attached to all of these people. I used to participate in all of the presidential things. And what to say about Sneha? She is today's director and she's eminent, hardworking, I can say, because I don't know where she gets the time. Today she is here and tomorrow somewhere else. Hardly she sleeps. But God bless you, Sneha. Let God give so much of health, strength to do so many things. Though your association with me is very short, but I have observed you so keenly. And how many things you can do at a time. And you have 10 brains and 20 hands, I think so. And I welcome all the participants and all the chairpersons. All of you are very close. Dr. Revati, Dr. Aarti, Dr. Uma, Dr. Sandhya. And one thing for all the speakers, what can I tell? The minute I called, all the speakers readily agreed with the topics ready. Dr. Jyotika, she's so helpful in changing the titles. That's what really, Jyotika, thank you very much. And Revati, she readily agreed. All of you are really, I am highly thankful to you. And much more than anything, Dr. Sneha giving a free hand to me to coordinate and do the program. Thank you very much. With this, I feel that Sneha should take over and invite everybody personally. All the best, Sneha, for your coming elections.
Thank you. Thank you, Madam, so much for your blessings. Of course, a very good evening to one and all. My respect and regards to our chief guest for today's program, Madam Jaideep Malhotra, who is my mentor since long, Dr. Hara Patnaik, sir, Dr. Jagesh Shah, and Dr. Sudha Sharma, ma'am, as a guest of honor for today's program. And of course, the esteemed faculties. We have the speakers, Dr. Jyotika Desai, who will be speaking and want to know more about sarcopenia. And of course, Madam Ambuja speaking on thickened endometrium, what next? And Dr. Revati speaking on prevention of NSAIDs, is MHT, menopausal hormone therapy, an option? I can see so many illustrious people here, Madam Revati Janaki Raman, Dr. Arti Gupta, Dr. Uma Devi, and so many. I can see Dr. I think Archana Dwivedi is yet to join. The esteemed chairpersons for today's program, Dr. Sujata Dalvi, Dr. Shobhana Mohandas, Madam, we were together for the one more program, and of course, Dr. Manik Panse. I'm very happy to have all of you on this forum. Madam has already talked about the name of this forum, that this is the benchmark. In this forum, we don't, include just speakers for the sake of going ahead with the program. These are really the authorities in the field who will speak on these topics, and I'm sure none other than what we have selected. And I'm very thankful to Madam Ambuja for taking the initiative and actually, executing the program as well. So thank you so much once again. And with this, let us go ahead with the program. And may I invite, I think, Sahiti? Yeah.
Just
so with
1 minute,
yeah.
Dr. Seha, we forgot to mention about Pooja Kadi.
Dr. Pooja
Yeah,
Kadi.
she
Yeah.
is the pioneer in her work.
Yeah, the vaginal
I recently
regeneration.
met her
Right.
in Raipur.
Mhm.
And she herself, when I was examining the students there, and she herself came out and told what
Yes.
wonderful work she is doing with this aesthetic gynecology. And I thought she is the
Yeah,
right
and
person to talk about it.
yes,
So you
Dr.
are
Pooja
welcome,
Kadi, about
Dr.
the
Pooja.
vaginal regeneration. She's speaking, and of course, we have Dr. Jyoti Jaiswal and Madam Sandhya Dixit as our esteemed chairpersons. As so, I welcome all of you for this program. With the blessings of God, yeah, Sahiti, we can go ahead with the invocation with you, and of course, we will have Madam Jaideep Malhotra's blessings. So, it is
Hello.
yes. Hello.
Yeah, are you able to hear me, Dr. Sneha?
Yes, please.
Oh, okay. Okay, good evening, I joined.
So I introduce Madam Jaideep Malhotra, who is my mentor. I think for me that is the biggest introduction for me. She has actually guided me. In fact, she is the driving force for me to come into Foxy. And way back 2005, we have developed a very good relation. Madam, of course, is the managing director of ART Rainbow IVF, and of course, she's the chair of FIGO REI committee, member of accountability group of PMNCH, WHO, vice president of INSAC, and of course, all of you know that she's a past president of Foxy, ISAR, Aspire, IMS, SAFOMS, and ISPAT. So we are really very, very privileged to have you, madam. The list of awards and accolades goes on and on, but rather than that, we would listen to your precious words of guidance. So over to you, Madam Jaideep Malhotra, for your words.
Thank you so much, Sneha, and a very, very good evening to all of you. Thank you, Ambuja, for thinking about me. It's such a pleasure to be with each one of you. And when I was going through the program, it was such a feeling, I said, oh my God, from where IMS has grown to, reaching where? Because the quality of the programs, the webinars, the speakers, the talks, it is really phenomenal. Today, when we look at in our own country, there are more than 130 million women who are in this age group, and most of them would be requiring a lot of awareness and knowledge. And along with that, quite a few of them would also need to understand why some things are really happening to them and what is the remedy or what is the management. And more than the management, I would say focus on the prevention, focus on them getting prepared for the times to come. And those are the things. And I'm so happy that uh, all these topics are very well dealt with, and you are roping in people from all over now, because IMS was such a closed group. Now today it is such a large family, and my heart really swells with pride when I look at, my very, very good friend Hara talking about what mature women want. Very recently, I heard him, Jignesh, following the ethos. And Sudha, now when I look at you, Aarti, Jyoti, and, my really swells with pride, because today I know that, yes, the health of our organization, and more so the health of the women of India who are in this age group, is going to be much, much better. And I would say that, as I look at the topics, there are certain things which, and I think not only certain things, most of the issues which we are discussing today, we need to work on them much before menopause sets in. And I would really request each one of you who are listening to me to focus on that. And that's where the Club 35 Plus actually was born. And today, when I say this, it's also very, very important for us to understand that when we talk about NCDs, the foundation of most of these NCDs is also laid in utero. It's not only in menopause, it just comes up and becomes more apparent. So if we look at and care about women's health at large, right from the womb itself, I'm sure the quality of life and the future generations are definitely going to be much, much more healthier. So kudos to all of you. Looking forward to hearing each one of you. Wonderful, wonderful speakers. And all the best to you, Sneha. I know, coming from a small town, working so hard, I I have no words but to say that, yes, well done, dear. Even when you have reached here, the amount of work which you are doing is phenomenal. And I know the challenges which any one of us faces when we come from, that small town. And then sky's the limit. I am sure, whatever, more strength and more power to you, and all the best for your future elections. So God bless you all. Looking forward to hearing the wonderful speakers. Thank you for having me.
Thank you, madam. Thank you so much for everything. I would say, right from accepting the invitation to the wonderful insight into the subject, and of course, the strength always you give me the guidance. Thank you so much. Now we move ahead with the guest of honor, Dr. Hara Patnaik, sir. I remember, sir has come to Yavatmal, and that was, everybody describes it as my coronation as Vidarbha Isabha president. And let me tell you that, of the four presidential candidates at the same time on the same dais, from Foxy presidential candidates. That is what wonderful program it was, and I still cherish the memories of your presence, sir. Dr. Hara Patnaik, whom we know so well, a very illustrious person, gentle human being, Secretary General Society of Vaginal Surgery of India, President of IMS in 2015-16, President of Association of Obs-Gynae of Odisha 2015-16, and of course, Governing Council member ICUG 2010 and 2012. So lots and lots, and I'm sure so many things are not mentioned here, but more than that, we would listen to your precious words of guidance, sir. Over to you, Hara, sir.
Thank you, madam. Dr. Sneha, it's a pleasure to meet you all and all the stalwarts of IMS and Foxy in one platform. And the credit entirely goes to you. See, for the first time when I went to Yavatmal, I could see the power couple, Dr. Surendra and Sneha. And they're a wonderful host, beautiful person, and I really appreciated your conference. I wish from the core of my heart all success for you in your all your future endeavor. I hope this time you will be definitely blessed by God and lucky again. Then benchmark is a really a benchmark in the management. You have taken many subjects, many topics, and this time we are happy that you have devoted this benchmark session to menopause. And we have wonderful, my friends, colleagues, and seniors, everybody of Indian Menopause Society are over here. Dr. Jaydeep Malhotra, she has achieved all milestones. I don't think anything is left. Function. Thank you for inviting me, Jignesh, and Dr. Sudha Sarma. Dr. Ambuja is my sister and a great personality, great academician, and Dr. Sobna Mohandas, and so on and so forth. I can go on and on, but I wish all the best for today's program, and I hope, with blessings of God, this will be a very successful session in managing menopause this time. Thank you very much.
Thank you, sir. Thank you so much. And with this, I hand over the forum to Madam Ambuja for inviting and introducing our guest of honor. Over to you, Madam Ambuja.
Thank you, Sneha. I don't know whether Dr. Jignesh has come or not.
Ma'am, sir has not yet joined, but Sudha madam is there.
Okay, so it's really, I feel honored to introduce Sudha, a great friend of mine. She is vice president, the present vice president, and she worked with me as secretary general in 21-22. That is the time, I think, Sudha, we used to talk twice or thrice a day to organize the
sometimes more.
More than that. Okay. Honorary Professor of IMA, Managing Committee Member, PCOS Society of India, and Editor-in-Chief, JMH. Even before she occupied any of the things, and a great thing for how many papers she wrote. And the good thing is, she used to encourage me to write many, many papers. She is member editorial board of Journal of SAFOP and SAFOMS, JK Sciences, and associate editor, International Journal of Obstetrics.
Thank you, Dr. Ambuja.
And she is founder president of Jammu Menopause Society. So, pearls of wisdom from Sudha, a very, very learned person.
Thank you, dear Dr. Ambuja, for such lovely words coming from you. They really mean something. So a very, very pleasant evening, everyone. So at the outside, I really want to congratulate Dr. Sneha. You are doing such an amazing work. We all know it. So as Dr. Jaydeep said, more power and more strength to you. We simply wish that. And we simply, want you to be successful in all your endeavors, whatever you do. And congratulations, Dr. Ambuja, for convening and organizing this benchmark menopause. Dr. Monica for coordinating. Topics which you have chosen, Dr. Ambuja, they are so very important because they are the least discussed ones. And I tell you, only if you yourself suffer from it, or your loved ones, they suffer from it, only then you realize. Because I know Dr. Jaydeep and Dr. Hara, they have said such meaningful and appropriate pearls and words for this menopause benchmark program. Sarcopenia, it is so annoying, I tell you, when you start losing your muscle mass from your favorite places and you start adding all the these fats on your unfavorable places. It is, I tell you, nobody has discussed it, but it is very disturbing and very annoying once you go through it and once you have it on yourself. All the other topics are very important, and I am sure the expert star speakers like Dr. Ambuja, Dr. Jyotika Pooja, and Revati, they are going to update us on these chosen topics, and the chairpersons are going to put their valuable inputs. Thank you so much for inviting me, and all the success wishing for this program. Thank you so much.
Thank you so much, madam. Thank you for those wonderful words as well. And of course, we are very eager to listen to your talks, academics as well soon. So thank you so much for your gracious presence, of course. Thank you. I thank all the luminaries. Monica, do we have Dr. Jigesh Shah, sir? No, I
No,
don't.
ma'am, not yet.
So he just messaged me that I'll join soon, but I think he will have his words whenever he joins. So I thank all the dignitaries here, all the chief guests, Madam Jaideep Malhotra, and of course the guest of honor, Dr. Hara Patnaik, sir, and Madam Sudha Sharma, all the esteemed and illustrious speakers here. We are really eagerly waiting to listen to you. And without much ado, I hand over the forum to Dr. Monica Umbadan to go ahead with the academic session. So over to you, Dr. Monica, for your, over to you for academic session.
Thank you, ma'am, for giving me an opportunity to coordinate this session. I also thank Dr. Ambuja, madam, for the scientific program and for convening this program. I would like to thank Dr. Jaideep, madam, Dr. Sudha Sharma, ma'am, and Dr. Hara Patnaik, sir, for gracing the inauguration ceremony. We start with the academic session, that is the talk by none other than Dr. Jyotika Desai, ma'am, on Want to Know More About Sarcopenia. Our chairpersons for today's session, Dr. Jyoti Jaiswal, madam, is a professor and head of the department at the JNM Medical College, Raipur. She is the vice president of the governing council member, ISAR. She has been the vice president of Raipur Obgyn Society, the secretary of IIG chapter, the national treasurer of IMS 22 to 26. She has held various positions in various organizations. We welcome you, ma'am, as a chairperson for this session. Our other chairperson is Dr. Sandhya Dixit, madam. She is a retired professor, president of the Hyderabad Menopause Society. We welcome you, ma'am. And I request Dr. Jyoti, madam, to please introduce our speakers for today.
Thank you so much, Monica, for making me. Thank you, Ambuja, madam, and Sneha, madam, to make me the part of this important webinar, where all the, I must say, the doyens of the Menopause Society are available. And before introducing Jyotika, madam, I would like to say all the best, Sneha, madam, for your future endeavors. Now, coming to the scientific program once again, I am feeling very happy to invite Dr. Jyotika Desai for her talk on sarcopenia. Madam is senior consultant, Dr. P.R. Desai Hospital, Bangalore. She is a DNB teaching faculty and national coordinator, Foxy Usha Krishna Quiz. She was chairperson education committee of Indian Menopause Society from 23 to 25 and honorary secretary ISOPAR Bangalore chapter. Madam has done so many things for she is a well-known icon for the Bangalore, and like she remained the past president of Bangalore Society, past president Bangalore Menopause Society, Foxy South Loan Quiz Coordinator, chairperson website committee, scientific chairperson of AICOG, a big task done at Bangalore, organizing chairperson of IMSCON, the National Conference of Indian Menopause Society at Bangalore, and apart from that, she is recipient of 4 gold medal in the MBBS and having Lifetime Achievement Award in 2017 from the Bangalore Society of Obs Gynae. So Madam has so many feathers in her cap, and we are very eager to listen to her about sarcopenia. Madam, stage is yours now.
Thank you. Thank you, Monica, having given me
very much, Jyoti, for that elaborate.
Okay. Jyotika, hi Jyotika. Please continue. Welcome.
Hi. Thank you very much for involving me, Ambuja and Sneha. This is a real benchmark program, and I'm really proud to be part of it. Thank you, Jyoti, for that kind introduction. So here we go. And Sneha, before I forget, all the best for your future. We are all behind.
Thank you so much.
Thank you. So now, yes, a very sensible topic chosen by Dr. Ambuja about sarcopenia, not much spoken about, not much thought about. So let us know more about it. It's not moving. Wait.
Please click
Ma'am,
on
please
the
click
slide.
on the slide.
Click
The
on the
slide.
slide, please. Click on the slide, ma'am.
Yes,
Yes.
ma'am. Now
Right.
it's moving.
So what is sarcopenia? It is a progressive and generalized skeletal muscle disorder that can contribute to falls, fractures, increasing disability, and also increasing mortality. The typical features of sarcopenia are loss of muscle mass and muscle function and increased fat mass. Now, it is defined as a loss in muscle mass less than 2 standard deviations of the youthful cohort. Not a very helpful definition for us clinicians. Maybe we can take the second one, which is decrease in gait speed under 0.8 kilometers per second. So, it's not going well. I have to point at this every time.
Ma'am, you can use the keys on your keyboard also, left and right.
वो नहीं जा रहा यारो.
You will need to make it full screen, ma'am.
Yeah, I did it, but it's not going for some reason.
बाकी काही नंतर एवढे काही चांगले गाणे नव्हते.
कोई बात नहीं, रहने दो. So, you can see the difference between a young healthy muscle here, the microscopic picture here, and an old atrophic muscle, which is sarcopenic. So, you cannot talk about sarcopenia. It's in the full screen. Yeah, you cannot talk about sarcopenia without mentioning menopause. We all know there's an increase in visceral adiposity, a decrease in bone density, and of course, a decrease in muscle mass and muscle strength, that is sarcopenia. Well, so what does sarcopenia mean? It means lack of flesh, and it was described as late as 1989. कुछ गड़बड़ है इसमें, कभी जाता कभी नहीं जाता. ओके, देखती हूँ इसमें होता या नहीं होता, नहीं हो रहा. Yeah. So what are the causes of sarcopenia? The most important cause is age. Aging can cause sarcopenia both in men as well as in women. Now, to just look at the facts, 25% of women and men more than 65 years old have sarcopenia. And again, if you're more than 80 years, 60% of 80 plus people are affected by sarcopenia. So apart from aging, what are the other causes? Inactivity. Yes, most of us are sedentary in our lifestyles with very minimal physical activity that can contribute to sarcopenia. Well, again, nutrition, overnutrition, undernutrition, and sometimes medication themselves can cause sarcopenia. I'll talk to you about it later. Well, diseases, yes, inflammatory, neoplasms, and NCDs. Why? For the simple reason that when we are affected by these conditions, our mobility comes down, and that contributes to sarcopenia, apart from other causes due to the disease itself. Now, I've already mentioned most of the causes. Let us look at some of the causes which we didn't come across in the previous slide. Mitochondrial dysfunction and decrease in motor units number. These are what happen in the muscle itself. And apart from this, the decrease in immunity with age, called immunosenescence, that also contributes. So it can be acute when it is less than 6 months in duration, chronic more than 6 months. It can be primary when it is related only to age, and secondary because of all the conditions I've already mentioned. It can be mild when only muscle loss is less, and it can be severe when muscle loss, muscle mass, muscle strength, both are involved. So what happens to muscle mass with age? I've already told you, but it's very important to realize that beyond the age of 20 years, there is a loss of 0.5 to 0.8 kg per decade. And once we are 50 years, there's a loss of 1 to 2% per year. Beyond 60 years, Muscle strength also decreases by 3% per year, and we know what happens as 80 years. Again, once we hit menopause, 0.6% of muscle mass is lost per year. So we need to be more careful about addressing our muscle mass and strength. So the consequences, we've just touched upon it earlier. Patient will complain of weakness, of disability. She'll have more frequent falls, and because of falls, she'll have fractures. And because of fractures, we know what happens after a hip fracture. 20% of them lose their lives within 1 year. Now, there are some important terms which we should all be aware of. One is myopenia, which is muscle wasting due to chronic disease. Then dynapenia, poverty of muscle strength and power. Can medication affect muscle strength? Yes, I've already told you. Calcium channel blockers, furosemide, statins, fibrates, and benzodiazepines can all contribute to sarcopenia. Now, whenever we come across a person with osteoporosis, don't forget sarcopenia. They are dissimilar twins and they'll always be together. So if you find sarcopenia, test for osteoporosis. And if you find osteoporosis, test for sarcopenia. Well, some more new terms. Pre-sarcopenia, low muscle strength without low muscle mass. Sarcopenic obesity, coexistence of sarcopenia and obesity. 2 stages have been described. Stage 1, where there are no complications related to altered muscle function and body composition. And stage 2, at least one complication seen, like a cardiovascular, respiratory, metabolic, etc. And there's one more one called myosteatosis, where there is ectopic fat deposition in skeletal muscle, usually seen in cardiometabolic disease. Now, this ectopic fat deposition can be intermuscular, intramuscular, or it can manifest as intramyocellular lipids. Now, why is this important? Because it can lead to muscle breakdown, chronic inflammation, and increased insulin resistance. So now, when do you suspect sarcopenia? Yes, if there is a history of unintentional weight loss of more than 5% in a month, most of the time we are very happy if we lose that much of weight, but when the woman hasn't asked for it and it happens, please think of sarcopenia. Then again, when there's a rapid weight gain, recent in women more than 70 years. Then again, when there is a weight gain when the patient is on steroids. Now, midlife obesity. We know in India, quite a few of us have been obese during the menopause transition. Now, there has been, and they have done studies to see that there is increased incidence of sarcopenia in such individuals later in life. A slow gait, less than 0.8 meters per second, and of course, unable to get up from a chair without support. So when do you screen for sarcopenia? The European Working Group on Sarcopenia in Older People, they have been very active in trying to get us the SARC-F questionnaire, which is very simple and easily doable. So one, when a woman walks into your clinic, you have to ask her the following questions. So first, you screen by history. So you ask her whether she's had a fall recently in the past 1 year, whether she's feeling very weak. Most of our patients say they're feeling weak, whether her walking speed has decreased, whether she's finding difficulty in rising from a chair, and whether, of course, there has been unintentional weight loss or muscle wasting. Now, the second thing is, in case when you get a history from her that, yes, I've had these problems, then you introduce the SARC-F questionnaire to her. It has 5 components: muscle strength, assistance in walking, rising from a chair, climbing stairs, and frequent falls. Now, each of these components is given 2 points, and the maximum is 10, which is the worst, and the best is 0, which is the best, of course. And if the score is 4 or more, the patient has sarcopenia. Now, how do we assess these 4 components? So the question is, how to assess strength. Ask her when she goes to the market and she carries a weight of about 4.5 to 5 kilos. Does she have difficulty? No difficulty, 0 score. Some difficulty, 1. A lot or just unable to carry, it is 2. Now, does she need assistance in walking when she's going across a room? Somebody has to hold a hand. None, 0, some 1. If she uses aids or if she uses a walking stick, yes, 2. Now about trying to get up from a chair or from a bed. She has no problem, 0, some 1. A lot or unable without help, 2. Climbing stairs, just a flight of just 10 steps. Does she have difficulty? The same thing again. And how many times has she fallen in the last 1 year? If she has never not fallen, then the score is 0. 1 to 3 falls, 1. And if she has had more than 4 falls, her score becomes 2. Now the total score I've already told you is 0 to 10. But if she scores more than 4, she has sarcopenia. Now, we know that she has sarcopenia, but now let us see what is the extent of sarcopenia. For that, again, the European Working Group has given us certain guidelines. One is the grip strength. Now, this grip strength, so you test for the hand grip as well as the leg one. So, for the hand grip, you need a dynamometer. So, you keep both your hands straight, elbows fully extended, and with a well-calibrated handheld dynamometer. You take 3 readings on both sides, and the highest reading is taken as her score. Now this, she should hold it only for 3 to 5 seconds maximum. The total time of the duration of the test is only 5 minutes. About the lower limb, she has to sit on a chair with her hips and her knees flexed at 90 degrees. And again, you get the dynamometer. And she has to extend her knees for 5 seconds against the dynamometer. So again, from this, they can find out, they can calculate the weight-bearing index. Then again, chair stand test. So this is again very simple, which we can carry out. For the previous one, we needed a dynamometer. But for this, we don't need anything. In your clinic, when the patient comes, make her get up from her chair 5 times and you time her 15 seconds. If she takes more than 15 seconds, the Asian group said 12 seconds, but the European says 15 seconds. If she takes more than 15 seconds, then you know that she has sarcopenia. Again, gait speed. You make her walk 10 meter, a flat corridor, no ups and downs there. Let her walk the first 2 meters, the last 2 meters. There'll be acceleration and deceleration. So except those two, take the 6 meters in the middle and let us see how she does it. And when you time her for that, and when you see that they have given it as 1 meter, but the Asian takes it as 0.8. So let us take it as 1.8 to 1 meter per second. If she cannot walk less, 1 meter within a second, then you know that she has sarcopenia. Now, muscle mass, we need bioimpedance analysis, which is not possible for us without these instruments. Let us look at a simpler way of calculating muscle mass. Calf circumference has come recently. If the calf circumference is less than 33 centimeters in women and less than 34 centimeters in women, suspect sarcopenia. Now, this is an algorithm which is very simple indeed, just telling you what I've just told you. So just to come to the right side, you can see that skeletal muscle strength, we know by grip strength and the chair stand test. The appendicular skeletal mass, that we know by the DEXA. Whole body skeletal mass by MRI. Physical performance by gait speed. And short physical performance batteries, a 400-meter walk or a long distance corridor walk. By doing all this, we come to a conclusion what she has. Fine. Now, this is something which all of us should remember, that reversing sarcopenia increases lifespan and does improve the quality of life. However, there are no medications approved by the US FDA to treat sarcopenia as of now. So how do we go about it? Well, exercise is the mainstay. Nutrition, I'll just touch each one of them. Hormone therapy, alternative therapy, and of course, experimental drugs. I'm not talking of experimental drugs again, so these are all still in the pipeline. Creatine, myostatin, AC inhibitors, ursolic acid, and PPAR antagonists, etc. So endurance exercise, yes, it can be weight-bearing or it can be non-weight bearing. Weight-bearing improves the mass and cardiovascular health by 10 to 30%. All of us need to do it all the time without forgetting. Then the ACSM recommends 30 minutes of cumulative exercise 3 times a week. Weight-bearing exercise, the examples are walking, jogging, climbing stairs, skiing, and aerobics. When you can stand, don't sit. When you can walk up the stairs, don't take the lift. So these are simple things which all of us should remember in our daily life. The non-weight-bearing exercises are swimming, rowing, and upper body exercises. Now let us come to resistance training, progressive resistance training. Very important, should be done 2 to 3 times a week. It improves all the functions which I just mentioned. And again, it should be done by all postmenopausal women. Posture and balance training, again, very, very important. It decreases the tendency to fall, improves our posture, and aids in a quicker response. Say you just miss your step, you lose your balance. If you do all this training, you can recover your balance and not fall and break your bones. It can be static, standing in one place on 2 legs in the beginning, later 1 leg, and still later only on the toes. We can practice it every day when we are listening in webinars. Or dynamic, using side steps, crossover steps, forward, backward steps, high steps, heel to toe walking, and toe tapping. These sound very simple, but they can be done on a daily basis. Now, can just walking reverse sarcopenia? Yes, it can. It can not only reverse, it can prevent sarcopenia. There was a Japanese study on 227 women aged more than 65 years, and it showed that 6 months of walking increased muscle mass, particularly in those with low muscle mass. What about nutrition? Yes, proteins. We all know proteins are bodybuilding and muscles need proteins. And we also know that Indians are very low on proteins. So 0.8 grams per kilogram body weight of proteins, the same as any other menopausal woman. Apart from that, these have been recently added: amino acids, vitamin D, selenium, magnesium, fish oil, and omega-3 supplements. They have shown promising results, but with exercise, they increase muscle mass, but they don't increase the strength. Please remember. Now, what about hormone therapy? Controversial. Increases muscle mass again, but not function or strength. But the positive point is it preserves balance and it decreases fall. So let us look at this aspect and be happy about it. And the funny thing is that the effect is very transient. What about alternative therapy? There are so many mentioned here. I would only like to stress upon isoflavones and tibolone. And of course, vitamin D. 70 milligrams of isoflavones for 6 months had increased in lean mass and muscle mass with decrease in fat mass. So you have to have a combination of isoflavones plus progressive resistance therapy training. Then again, tibolone is one which definitely increases strength, lean body mass, upper body strength, lower body strength, and also decreases total body fat. DHEA, not sure. Growth hormone, no. Exogenous doesn't work. Endogenous pulsatile effect is not possible at that age. Vitamin D, yes, it reduces falls by 23 to 53%. And if your vitamin D levels are between 75 to 100 nanomoles per liter, then your bone and muscle health are in optimum condition. So what is the way forward? My dear friends, whenever a menopausal woman comes, ask leading questions and do the SARC-F score. Very important. Keep the SARC-F score as a printout under your desk table, under your glass top on the table, so that you know it will be a ready reckoner. Then again, if the score is more than 4, assess the severity of sarcopenia by doing the chair rise, the grip strength, and the gait speed tests. Find out whether sarcopenia is age-related or secondary to other causes mentioned earlier. Loss of muscle mass can be confirmed by DEXA or MRI. Strength you're checking, but mass we have to check by these 2 methods. Screen all old women in old age homes. There are plenty of old age homes and plenty of old women. We have to screen them not only for osteoporosis, but also for sarcopenia. Screen women with CVD, CKD, heart failure, etc. All chronic ailments and also cancer for sarcopenia. And think sarcopenia always. So sarcopenia, especially the age-related muscle loss, can be prevented by all these measures. Prevention is the key. So, my dear friends, let us all start today by looking after ourselves and our patients and preventing the onset and the progress of sarcopenia. Thank you very much for a very patient hearing.
Thank you, Dr. Jyotika. Wonderful, as always. Wonderful presentation.
Thank you so
Simple,
much.
succinct, and wonderful. What we should do, what happens to us with muscle loss, and very, very important to know. Osteosarcopenia, that should be the word now for the menopausal women. Fantastic, wonderful.
So, charity begins at home. So, we look after ourselves first and then look after our patients.
Yeah, very
Yeah,
nice.
we should look after ourselves. Yeah.
Because nowadays we all are in that particular age where from this time only we have to take care about our future sarcopenia as well. We'll not take care at this time, as Jaideep madam said, that's why the club 35 plus is take care of the women's health well before time so that they can do better in their second inning. So thank you very much, Jyotika madam, for enlightening on this important subject.
Thank you, Jyoti. Thank you so much.
Thank you, Jyotika madam, for an excellent presentation. And thank you, Sandhya ma'am and Jyoti ma'am, for sharing this session. We now move forward for the next academic talk by Dr. Ambuja madam on thickened endometrium, what next? And our chairpersons for this session are Dr. R.P. Gupta madam. He was the Secretary General of the Indian Menopause Society, the President of the Agra Obstetrics Society. She was also the chairperson of the Indian Menopause Society, the Public Awareness Committee, the Club 35 Plus. She is also the founder of Saath Saath Group, which is an NGO, which is a social group of 200 members which are aimed at spreading health awareness. She has been the chapter secretary of Agra Indian
Thank you,
Menopause
Monica. Monica, thank you so much.
And our next chairperson is Dr. Sujata Dalvi, madam. This is her old CVAT. Madam is currently the zonal coordinator of AMOX of Zone 1. She's also the president of the Mumbai Menopause Society. She's an honorary clinical associate at Adwadia Hospital and Jagjeevan Ram Railway Hospital. And she is the past secretary of the AMOX. We welcome you, ma'am, as the chairperson for this session. I request Dr. Aarti ma'am to please introduce our speaker, Dr. Ambuja ma'am.
Thank you, Monica. Thank you so much. And it's my proud privilege to introduce Dr. Amuja ma'am. And Dr. Amuja ma'am is the President Indian Menopause Society in 2021 and 22. Retired professor and head of the department, Obstetrics and Gynecological Department, Osmania Medical College, Hyderabad. Visiting Professor, Savita University, Chennai. All India Vice President, Family Planning Association of India. President, FPAI, Hyderabad branch. Faculty and Resource Person, National Board of Examination, DNB from 2000 onward. Treasurer, SOMI, Society of Obstetrics and Medicine of India. Ma'am, thank you so much for being here and for giving this important deliberation. And I know कि जो बोलेगी बहुत अच्छा बोलेगी. So welcome, ma'am. I invite you for this prestigious lecture.
Thank you very much. Can you please stop sharing, Monica?
Yes, Saiti, please stop sharing.
Yeah.
No, ma'am, it's Dr. Ambuja ma'am's desktop. Ma'am, please minimize this, ma'am.
Please minimize. Yes.
Yes, please click on that.
Shall I start again?
You need to open your PPT. This is the flyer which has been opened on your.
This is my
I guess
PPT.
you need to
Are you able
reshare
to
it,
see
ma'am.
or not? You are not able to see?
Ma'am, it's not your PPT. Ma'am, please reshare it, ma'am.
Open the PPT first and then share.
Is it okay? Are you able to see?
Yes, ma'am.
Yes.
You are seeing. Is it full screen?
No, yes, now it's full screen, ma'am.
Yeah. Thank you very much, Aarti, for your kind introduction. And thank you very much. Before starting, I can say one word about Jyotika. It is so crystal clear what you presented, really. And I am never wrong in choosing you for anything. Our association is about 4 decades old. So I know you all in and out. Thank you very much.
Don't frighten me, Ambuja, by saying in and out. Thank you so much.
Out
I know.
only, not in. When proceeding with the thickened endometrium, what next? This is a case what we get it day in and out. I thought we should solve the problem somehow. All of us know that inner layer is the endometrium and it is a dynamic, always. Changes in the menstrual cycle according to the hormones that are produced. And it has got both estrogen and progesterone receptors which respond to the hormones not only in the reproductive period, but in the menopausal period also. And whenever the estrogen is more, definitely proliferation is present. But the thing is, this endometrium will not respond only to the progesterones if it is not primed with the estrogen. That's what is very important. So estrogens are the one which mainly proliferation takes place. So is all the thickened endometriums, is it abnormal? What we are worried about the thickened endometrium, what we say to the patients, or so many times we get it, is we are worried about the cancer when it occurs in the perimenopausal and postmenopausal age group. Is it so? How do you differentiate and say that which type of endometrium is bad and which is not? So what is the significance of this thickened endometrium? Thickened endometrium is not a clinical diagnosis. It is an ultrasound diagnosis. Proliferation may be estrogenic or estrogen primed progesterogenic, means which is physiological, where the glands and stroma ratio is maintained. But endometrial hyperplasia is a histopathology report. It is not an ultrasound report. And endometrial hyperplasia frequently results from chronic estrogen stimulation, unopposed by the counterbalancing effects of progesterone. In 2014, WHO has made the classification as endometrial hyperplasia without atypia and atypical endometrium. Endometrial hyperplasia with atypia is a precancerous condition. Do you know that just thickened endometrium is not a cancerous condition? Without atypia also is not a cancer condition. With atypia is a precancerous condition. Means this has not invaded the myometrium or basement membrane. So usually they present with the symptom of peri and postmenopausal bleeding. Main idea is to suspect and detect endometrial cancer, because for endometrial cancer, there are no screening methods like breast cancer or the carcinoma cervix. So what is the role of imaging? The first and foremost thing is the vaginal ultrasound is the gold standard for this. We cannot come to the conclusion that it is a endometrial when thickening is present just by doing the abdominal ultrasound. Both of them are complementary to each other. Transvaginal ultrasound evaluates uterus, endometrium, and adenoids. Best is 2D ultrasound, vaginal ultrasound, but Doppler is only in suspected malignancies, not necessary to have a daily basis, because this is a third hand of the gynecologist. All of us should know to do the scans by ourselves. Then only it is easy to come to the conclusion what type of thing is there. If there is difficulty in differentiating myoma and adenomyosis, we can use it. And of course, saline infusion sonography to delineate any intracavity lesions, and 3D to delineate intracavity lesions, map myoma, and uterine anomalies. I say it is more of fancy to use 3D, not a daily basis, it's not necessary also. MRI also to differentiate between adenomyosis and myoma. It is more useful to know the depth of myometrial involvement in case of endometrial carcinoma. What is the risk of endometrial carcinoma in thickened endometrium? This is very important. Why are we bothered about it? Suppose if it is a physiological thickening where the endometrium report comes as the proliferative or secretory, this going into malignancy, that is the risk is 0%. So many times they come to us when we do DNC because it is a 23 millimeters, a cheesy like material comes out, and we always think that is it a malignancy, but the final result comes as a secretory endometrium because they used lots and lots of progesterone, and so that ended with the cheesy material. That's not a malignancy. Even if hyperplasia is present, simple hyperplasia without ATPI is only 3% will go in for malignancy, and with ATPI it is 29%. So now the dilemma comes, what thickness of endometrium which requires intervention, and what is normal endometrium and what is abnormal endometrium. This all depends upon so many factors. Is it a premenopausal, perimenopausal, or postmenopausal patient? Because in each condition, the endometrial thickness differs, and whether it is a symptomatic patient or asymptomatic patient, whether she is on medication like hormone therapy or tamoxifen. So we should see all these things before deciding what are the cutoff points for this. So before going to that, I thought I'll give the case scenarios what I came across. It's a 45 years lady, corporate, went for corporate checkup. Abdominal ultrasound, endometrial thickness was 16 millimeters. They advised to consult gynae for hysterectomy. That is the thing. Because, ultrasound specialists are not gynae trained. And just like that, they will say the patient, and patients are so scared by listening to all these things. After 1 week, she's an asymptomatic patient. After the period, she came to me, transvaginal ultrasound, it was only 6 millimeters. So before going to anything, what are the essentials before measuring the endometrial thickness is very important. One is history taking, age of the patient, and which day of menstruation it is, because the endometrium changes in the post menstruation, or is it in the ovulatory phase or secretory phase or during menstruation. Ideal of time to do the vaginal scan is after cessation of periods or peri-ovulatory when we do, as the focal endometrium and pathology can be easily detected. We should know what is normal values in pre and perimenopausal patient. During menstruation, it will be 2 to 4 millimeters, and late proliferative up to 11 millimeters is normal. Late secretory 16 to 18 millimeters is normal. So should never think that 18 millimeters is wrong. And whenever the patient is taking combined contraceptive pills, the endometrial thickness reduces. Looking at the endometrial thickness, can we say that it's a malignancy? I always told you the gold standard is only histopathology, but still we can suspect if the endometrial thickness is more than 20 millimeters and loss of endomyometrial junction, if it is present, we can suspect that there can be thick. Is it the same for the postmenopausal? Definitely not. The postmenopausal endometrium is thin, homogeneous, echogenic, and less than 3 millimeters. This is the normal endometrium. But one thing we should understand, so many times we see patient comes with a thin endometrium. After 10 years, again she gets the scan and comes, the endometrium will be thick. That time she will ask, am I at risk for endometrial carcinoma? What we should know is, this is a recent one, it has come in 2002. Endometrial thickness decreases for the first 5 years after menopause by 0.03 millimeters per year. Later on, it maintains static for 13 years. Then there is slight increase in the endometrial thickness, 0.01 millimeters per year, most probably because it is age-related or central obesity, or maybe the cause which contributing estrogens, and then because always endometrium is responding to the estrogens from wherever they're coming. The cutoff values for the postmenopausal value is entirely different. Postmenopausal, if the patient is symptomatic, like bleeding, if it is present, the cutoff is 16 millimeters in the secretory fields. That is abnormal. With obesity, it comes down. Obesity is a risk factor. So obese patient coming with the bleeding, if it is more than 11 millimeters, you need to interfere and do the test for her. And persistent erratic menstrual bleeding, if it is present, perimenopausal, more than 12 millimeters is abnormal, and postmenopausal, more than 5 millimeters is abnormal. If the patient is asymptomatic, symptomatic, it is a different one. What is asymptomatic one, which is abnormal? More than 11 millimeters EB, endometrial biopsy is a must. If the patient is tamoxifen without bleeding, we can take normal up to 8 millimeters. If it is more than 8, need to do investigations. And if the patient is on MHT, asymptomatic, 8 millimeters is the cutoff point. So there is a lack of consciousness on cutoff values in the peri and perimenopausal patient, but it is very clear in the postmenopausal patient. What are the cutoff values? 3 millimeters is the cutoff value. Suppose if it is more, the amount of, I will tell you what is the specificity and sensitivity of the cutoff values at the latter step. Now, how to avoid overestimation of the ET? This is very, very important. Many a times when I see, I will give as 10 millimeters and the other person may give 12 or 13 millimeters. What to believe? Certain things we should take it into consideration. Whenever we do the scan, I told you better we do our scans by ourselves. The midline sagittal image is necessary. It should not be oblique and it should not be close to any one of the cornua that is there. And endometrial echo, it should be in continuation with the cervical echo. And endometrial thickness is the sum of two adjacent endometrium we should take, that is called the endometrial echo complex. This plus this. So in the center, we don't take it into consideration. Then only we'll get a proper estimation. With all these things, what did we do for this case? It's only counseling and said that nothing wrong with you. Take care of yourself. The next case, a 61 years postmenopausal, spotting on and off for 4 months. Endometrial thickness is 3 millimeters. Uterus normal size and adnexia are normal. Color Doppler showed no abnormality. The question is initial evaluation by sampling for all the patients? If it is a perimenopausal, single isolated bleeding event, not necessary to go for invasive procedures. But if it is a postmenopausal, single episode of any postmenopausal bleeding should be done should be evaluated, and we should know the histopathology. I think I am clear in that one, what to do with the perimenopausal and what to do with the postmenopausal. So how do we get the samples? Endometrial sampling, what are the procedures? One, pupil aspiration, conventional DNC, and hysteroscopic guided DNC is there. Of course, nothing is available in any of the rural areas. We may go for DNC, but when things are available, pupil is very cheap, anybody can do it. So, accuracy of detection of endometrial cancer by ET in the postmenopausal women, that's what I told you. If it is 3 millimeters, sensitivity is 97%, means it's very sure. Most of the times it's nearing 100%. There is no cancer. 4 millimeters cutoff, if you take 94.1, and 5 millimeters, it is 93.5%. So what is the difference? Which is good, that papilla or histoscopic guided biopsy? Everybody will not have the histoscope to do it. Of course, nowadays office histoscopy is very easy. No need of anesthesia or any where the patient is old, contraindications for anesthesia also we can take up. But it's a thing little costly. Not many people are having. Papilla, postmenopausal patient, it's 99%. It gives a positive report if there is a malignancy. In the perimenopausal, that accuracy comes down as to 91%. It is more sensitive if pathology is global. And if it is confined to one area where, like adenomyosis, if it is present, those patients need histoscopy that is preferred. This is another patient who came to me still recently, only yesterday I did histoscopic polypectomy. Still reports are not ready with this patient. She is 61 years, 15 years postmenopausal, asymptomatic, and came with the scan report, bulky uterus, endometrial thickness is 22 millimeters. When I did vaginal scan, there is a clear endometrial polyp that is there with fluid in the uterine cavity. Usually for such patients, we need to do the saline infusion salpingography. But for this patient, without doing anything, already there is a fluid inside. So because of this, I didn't do any of the other things, and color Doppler showed not much of vascularity. So immediately I proceeded for the histoscopic polypectomy for this patient. So what is the significance of fluid in the endometrial cavity in the postmenopausal women? What we should know? It indicates there is cervical stenosis. Asymptomatic postmenopausal endometrium is 3 millimeters. No hyperplasia, means there is no cancer. But if it is more than 3 millimeters, it should be biopsied. Yes, in this case, there was difficulty in dilating the internal os, even though misoprostol, I kept it for 200 milligrams before starting the operation, but there was difficulty. I did it under anesthesia, and lot of fluid came out. I was looking at that, why so much of fluid is coming. Later on, this is the cervical stenosis where the fluid was present. And here again, how to see for the endometrial echo complex that is there. This is what the polyp I removed. And see the endometrium, which is atrophic endometrium. In atrophic endometrium also, sometimes there will be bleeding and spotting will be present, because if there is no fluid, the endometrium will be there is friction that will be present, which leads to ulceration and bleeding, that we should keep it in mind. So this is a algorithm for the perimenopausal patient. After doing the TVS, if the thickness is a focal thickness or diffuse echogenic homogeneous is present, we will go for the endometrial biopsy. But endometrial thickness, if it is more than 16 also, we will go for biopsy. But if it is less than 4 millimeters, we'll give the conservative treatment. And if it is not responding to the treatment, we'll go for the biopsy. So endometrial thickness, more than 11 millimeters, and this is more significant. But in the postmenopausal women, if the endometrial thickness is more than 4 millimeters, we are directly going for the endometrial aspiration. If it is less than 4 millimeters, we'll wait and see. And the bleeding, if it repeats, definitely we have to do. If there is no bleeding, there is no worry. Only assurance, that is very important. But for HRT and tamoxifen, the limit is 8 millimeters. So not all the endometrial, thickened endometrium is cancer. That's what we should convey the message, because all of us are menopausal experts. We know what it is. But like Aarti, when you are doing the awareness campaigns, because she is the one who does many things, Sandhya and you should tell the patients that not all thickened endometrium is cancer. We should identify which patient is going for carcinoma or not. And it is a histopathology report. And ultrasound specialist cannot give the report saying that it is the cancer. So, and at the same time, exclude the polyps, and message is we should do scans of our. Thank you all for listening patiently. I hope I conveyed little message. Thank you very much, Sneha, for giving the opportunity. Namaste.
Okay, so
Madam
thank you, Dr.
Ambuja,
Thank you,
very,
Dr.
very
Ambuja,
good, madam.
Hello,
for
good
a
evening,
very
ma'am.
nice scientific deliberation. What was more important is endometrial hyperplasia does not mean that it's always a precursor of an carcinoma endometrium. We need to do a transvaginal sonography to get an accurate measurement of an endometrial thickness. And of course, there are different measurements of endometrial thickness so far as proliferative phase, secretory phase, postmenopausal phase. And you said in postmenopausal women, if ET is more than 20 millimeters, and if there's loss of myometrium and endometrial interface, then there are more chances that it could be an endometrial precursor of an endometrial carcinoma. And in these patients, biopsy is a must. And in case, whenever we are suspicious, always better to do either a pupil biopsy, or if at all diagnostic hysteroscopy is available, office hysteroscopy is available, so we can put in an office hysteroscope and collect an endometrium and send it for histopath. So very nice and very clear-cut guidelines so far as an endometrial hyperplasia is concerned. Over to Dr. Aarti Gupta if she wants to comment on the topic that Dr.
Dr. Sujata, you have told
Ambuja.
each and everything. I think nothing more is needed to talk about. But Dr.
Okay.
Ambuja, presentation is very good, very clear. Thank you so much, ma'am. But the most important message today is this: कि we should, whenever there is any patient of the postmenopausal bleeding, we should go for the transvaginal ultrasonography, and if needed, we should do the pupil biopsy, which is required and which is very important. We should not go directly to the hysterectomy, which most of us are doing, and that is the only message that we should save the uterus as much as we can. That is the only thing. Thank you, and thank you, Dr. Sneha, and all the best wishes for your coming endeavors. Thank you so much.
Yeah, even from my side, Sneha, Monica, and best wishes to Sneha for a future endeavor in Foxy, Sneha. Thank you.
Thank you, Ambuja, madam. It was wonderful, madam. Very clear, very.
Thank you, madam.
Namaskar.
Thank you, Dr.
Dr. Shobna.
It was
fantastic.
Lovely
Dr.
talk, Dr. Ambuja. Nice.
Nice
to meet all of you once again.
Thank you very
Yeah,
much.
yeah. Dr. Ambuja, it was lovely, listening to you. Such clear-cut messages you've given, and very important message which you conveyed at the end of it, that we need to counsel the patients. Anybody who gets with, thickened endometrium, they come, with a scare face that now we are going to have, endometrial carcinoma. It is better to get it removed.
Yes.
So the last message was very, very important because,
And
it
she
gives
showed one
benefit.
polyp in an atrophic endometrium.
Yeah.
So that's very nice. She practices what she preaches.
Thank you, sir.
Yes.
Shobna and Sudha.
Yes,
Thank you very
madam.
much.
Yes, madam. Ambuja, madam. Very nice presentation. Very useful for us practitioners. So it reduces hysterectomy incidence, I suppose.
Thank
Knowing
you
it.
very much.
But if I can ask you, Ambuja,
Yes, madam.
I mean, endometric 70, 75 years lady with atrophic endometrium, but a polyp looking like that in the ultrasound TVS, and then later on biopsy and all done. Can we suspect and asymptomatic, can we suspect with this endometrial thickening is not there, but there is local polyp. I don't know if there is in that area only there is a thickening. So in which case can we, think of a malignancy in that patient with this no hyperplasia,
Madam,
no
always
endometrial thickening.
in
It
Yes,
is
ma'am.
rather atrophic endometrium, but it is there is a small polyp which is looking like this, and then all other investigations have been done further. But with this TVS, can you make out that is there a chance we can think of, like there is a polyp, likely chance of a, probably even if she is asymptomatic, there is a likely chance and we have to rule out the malignancy by biopsy. But that is understood. But I want to know localized thickening of the endometrium, has it given any that polyp and how to make it out that?
Definitely, madam, any postmenopausal women, you should suspect. We cannot say
No,
that.
suspect is over. But my question is the atrophic endometrium everywhere and localized near the polyp only.
Without
Whether
hysteroscopy, you
Stethoscope.
cannot make out.
Atrophic endometrium,
Sir, madam, without
polyp when it
hysteroscopy,
is
you cannot
present,
make out.
there is chance of carcinoma 6.6%. So
Can I?
you should not leave it. You should take the polyp by hystoscopy and do the
Sometimes even thickened endometrium, madam, I've seen granulosa cell tumor of the ovary. And very normally you would miss it out. Only
And
recently I had
secondly,
done a
what
hysterectomy
we
for a
don't
my
patient.
question is
think of
not
it as
that
a
one. My
thickened
question is
endometrium
localized thickening of endometrial.
Without
Can
hysteroscopy,
you
you
make
cannot
it
say.
out properly?
No, madam. No.
Dr. Ambuja,
Without
can I say
hysteroscopy, you
something?
can't make out.
carcinoma is only histopathological classification.
No, that is over because I know that it has to be biopsied at that age, even whether it is atrophic
Without
or not.
biopsy, we cannot
Can I
say,
say
madam.
something?
Dr. Uma Devi also wants to say something.
Can I say something?
Yes, yes, madam.
Madam, please. Madam.
Okay.
Sudha, madam,
No,
please.
please. Okay. So, madam, when you suspect, polyp, TVS is not the ideal investigation.
MRI.
It has to be, adjunct with SIS. Because if you have uniform endometrial thickness, then TVS has a value. If you have, local polyps or something, you need to have other investigation. Number one. Number two, non-bleeding polyps, very less chances of having carcinoma. Number three, you need to have colored Doppler. If the,
Yes,
if the thickness of the pedicle of the polyp is more than 8 mm, then you suspect endometrial carcinoma in that.
And then we have to see that is there any bleeding or is there any circulation or not? Is there any flow in that growth? If there is a flow, then we will suspect the cancer. But if there is no flow, so then we can wait.
Yeah, and now
On color Doppler.
color Doppler is more
Once
important.
there is a polyp, we cannot leave it.
Yeah, and that
Madam,
polyp
as a part of screening, many women come for the general checkup and they will have a scan wherein the endometrial thickness will be more, and all the endometrial thickness which is more is not always a thickening endometrium. It can be a polyp. And transvaginal will make only few things, few times, but not always. So we do always the gold standard, the hysteroscopy, wherein the majority of them will see only polyps, not thickened endometrium, only majority of them polyps, not always a thickened endometrium. And the stalk is more important. When we do when we do a biopsy, when we cut off that polyp and send for histopathology, near the stalk usually, at least one person where I did, there was an adenocarcinoma. And so the stalk is more important, where the base of the polyp is very, very important for the histopathology.
There was
adenocarcinoma can be there.
Any polyp.
There was no
We
stalk.
can't just to do it like that. Color Doppler is very important.
Yeah, I
Either you
think
do a
That
color
will tell
Doppler is important to see
color
the
Doppler probably
blood
is the
flow, how
most.
much it is.
Yes.
Because you know,
So-
most of
Vascular
the
polyp,
times
yes,
we have
vascular
color
polyp
Doppler
has got
because
its own importance.
But even without that color Doppler also, ultimately we have to go for a hysteroscopic biopsy, polypectomy. And that, unfortunately, it turned to be a serous carcinoma of the
In
type.
all polyps, when we send,
6% of
the
the
stock
cases,
might get a
polyps will have
adenocarcinoma picture.
Carcinoma. So you
Madam,
should always
excellent
suspect.
the answer that though the not a very high number of cases can be malignant in such condition, but in the Indian Menopause Society guidelines also it is mentioned that even if atrophic endometrium is there and there is focal thickening or there is some at some part thickening or a polyp is there, we should always go for the gold standard and find out it, should take the biopsy and come to a proper conclusion, which we should not leave any stone unturned for leaving any thing that could be a malignancy. So, madam, if you have given the question and you yourself given the answer that finally it came out to be a cancerous thing with the help of the hysteroscopy.
Yes, it came as a serous endometrial cancer. And,
Yes. So you should not
histopathology in the A type 1.
hysteroscopy, and that is gold standard. And because it is invasive, it is minimally invasive. We should always offer, at least in our prescription, we should never leave that it has been prescribed. Otherwise, we should be in a soup.
Yeah, but ultimately that is sure that you have no other choice except to do a biopsy. But I was wanting to know whether there is local endometrial thickness, would it be there? And which
Thank you
he said
very much,
you have to
madam,
do
for
a
your
color
input.
Doppler. So now I'm more clear about the color Doppler.
Yes, ma'am. Color
Thank you
Doppler has a
for
very
your
important
inputs,
role.
Madam Pushpa Srinivas. Thank you very much.
Thank you, Ambuja, for enlightening us. Enlightening me, rather.
No.
Everyone.
Thanks, madam.
Thank you.
The people
You all have
to
been
you,
enlightened.
madam. You are great always.
Thank you everyone for a very fruitful discussion. Thank you Aarti ma'am and Sujata ma'am for chairing the session. And thank you Ambuja ma'am for highlighting the importance of screening and transvaginal ultrasounds for thickened endometrium and the role of color Doppler. We move on to the next session by Dr. Pooja Kadi madam. Can we have the slides, Saiti? This lecture will be on vaginal rejuvenation. Our chairpersons for today, Dr. Shobhana Mohandas. Madam has been the past president of Indian Menopause Society, a senior vice president of IMA Thrissur. She has also been in the past vice president and secretary general of the website
It's
committee.
okay. I'm only the chairperson. You introduce the speaker.
Yes, ma'am. Our next chairperson for today, Dr. Mani Pansaranam. She is a senior obstetrician and gynecologist, a director of Anant Multispecialty.
Thank you, Monica. Thank you.
Thank you so much, ma'am. Thank you both of you for accepting our invitation for being the chairperson for this talk by Dr. Pooja Kadi madam. I request you to please introduce our speaker for today.
Our today's speaker is Pooja Prashant Kadi. Oh, she's so beautiful. She's fertility consultant in Raipur, author of Garbha Sanskar. It's very near to me. And pioneer aesthetic and functional urogynecology. Mrs. India Noble Doctor Classic 2023. It shows, she's so beautiful. Won first prize in National Anemia Mukta Bharat Rangoli competition. She got lot many to her credit. And she is coming with such a beautiful and such a new topic after such frightening things of menopause like hyperplasia and sarcopenia. She'll be telling us something good about menopause, what she can do for us.
Yeah, good evening, everyone.
Ma'am.
Good evening. Thank you. Thank you for the nice compliments, ma'am. Thank you so much. And I would like to thank, first of all, Ambuja ma'am for picking me for this topic. Thank you, Sneha ma'am, Monica ma'am, for organizing this wonderful webinar. So I'll start sharing my screen. So today's topic is very close to my heart because it's been like around 5 years now that I am practicing this. And recently we met Ambuja ma'am at Raipur in the conference, and she picked like, I don't know when she pointed out, because we had a poster presentation that time we discussed about this. And first I would like, this will be I hope it will be an interactive session. You can chat in the chat box, and I want to highlight few things first, that how many of you love yourself? Type yes or no in the chat box. Just we are all the seniors and friends, so just I want you to reply something, what you feel about yourself. Do you love yourself? Do you love your family? Do you love your husband? So it's all about you, yourself, and your family. So it's
Yes.
all about vaginal rejuvenation. It's nothing like we should not be ashamed of talking about. We have talked so much about bone health, our cardiovascular health, our muscular health, our reproductive health, and menopause. So many aspects we are dealing with in menopause nowadays, and it's a one of that one component of changes which are occurring in menopause or after childbirth or after any like problem if the patient is having. We can deal with the aesthetic and urogynec branch.
Ma'am, please make it as full screen, ma'am.
It's full screen from my side.
It's
It
not
is not showing.
as ma'am. Yes, ma'am. Kindly reshare it, ma'am.
Okay.
At first, please stop share and then start
No, I
sharing.
think it is it full screen, because I can see most of it.
It's full screen or not? Please share it.
You just make it slideshow and see.
Yeah.
It's full screen, Dr. Pooja.
Yeah.
It's full screen. I'm getting
Then
full
change the
screen.
view. You make it instead of speaker side, you make it a gallery view. That's maybe the reason.
Okay.
Go to the view and change your settings, Aarti.
Okay, so just a brain teaser. थोड़ा सा हम like वो refresh कर लेते हैं. What do you call a person who loves to travel? Anybody knows? They can chat. They can type in the chat box, or they can speak out. Anybody know who loves to travel? What we call that person who frequently travels or who loves to travel? Who loves to sleep?
Traveler.
Yeah, traveler. Or there is a term called file. We can like who loves to do something else, so we attach the word file after that. So it's a hodophile for the traveler. Who loves to sleep? They are called as, like gynecologists and especially obstetricians. As we obstetricians, we love to sleep whenever we get time. So it's a cleanophile. Cleanophile, yes. Who loves to click photos? Pardon? Who loves to read or collect books? What will you call them?
Collect.
Yeah. Pardon?
Love collect what?
Your voice is not clear. You can type in the chat box. Which and who loves to learn and use new technologies? They are called as technophiles. So in all, who loves to attend all these seminars and give us like update yourself? We are all the collectively these kind of people who loves to travel, who loves to meet people, who loves to collect and read, who loves to learn new technology. So it's all about new technology which we are applying in our gynae field. So it's aesthetic and functional gynecology. It encompasses procedures to change which are used to change aesthetic and functional aspects associated with courses of life like childbirth or menopause or aging or genetic changes or congenital abnormalities in genital area. It depends on the exact needs of the patients. It's not a uniform or universal rule. It all depends how the patient wants to be, not even her husband, her herself. If she wants something to increase her confidence, or if it is she's having any problems because of that and it is affecting her daily life or self-esteem, then we can give her these treatments. They can be surgical or non-surgical procedures, and they are being used since ancient times. There are many literature which are describing vaginal surgeries, and now we are dealing with them in non-surgical ways with the help of new technologies. So it is not normal to leak urine after normal delivery. There are so many things which are unspoken, unsolved, and we have to change the mindset and menopause. And with menopause, there are so many changes, and we have to change that it is going to happen, and we have to bear with it. No, we don't have to bear with it. Now we have a solution. We have the options. We have the non-surgical options also, which we can take easily, like a facial. You're taking and coming and going back to your routine. Like that, you can go with these treatments also. So aging, it appears, it should be graceful. The aging should be graceful. It should be old wood best to burn. It should be like old wine to drink, and it should be old friends to taste. And like, sorry for the thing, it should be old authors to read. So so it is like so we are coming with the silent sufferings. These are all, and how we can treat it. What is the evidence-based medicine? We'll see the mechanism of action. We'll see the schedule of these treatments. We'll see the results and who will be benefited. So there are ablative and non-ablative lasers. There are two types of lasers which
I'm
deals
sorry
with
to interrupt, but your slides are not moving, ma'am. If you are changing the slides, can you please see to it?
Okay, just a minute. There can be a lag. Can you hear me?
Yes, ma'am.
Hear you, but it's on the first slide.
It's on the first slide only.
Yeah.
Yes.
Title slide.
Okay, I'll stop and I'll reshare.
Put on slideshow. Slideshow.
Yeah. Now it is visible?
No. The first slide is visible. It's not on slideshow yet. It's just rotating it.
From
It's okay,
my
but at
side.
least, but first slide is not moving.
Okay, from my side, it is actually moving. I don't know.
It's not moving here.
Sure, you completely put it off and go to the share screen. And from
Yeah,
there,
I have.
Ma'am, you need to minimize
on the PPT.
minimize this window.
But the screen is shared. It's not moving.
You have shared in the
You can see the first slide. That's all. The rest of them are on the side.
Ma'am, you have shared the window. You need to stop sharing, open your PPT, and then just select that screen.
Yeah, share screen and then select.
Now it is visible in the short window. Now I'm going to make it slideshow. Now can you see?
No, it's not gone into slideshow. It was rotating. Anyway, it's on the first slide now.
I hope it is visible now.
The first slide is visible.
Monica, she will do it.
Ma'am, it's a big presentation.
Ma'am, if you can send it to me either on mail or on WhatsApp, then we can show it from our end, ma'am.
Yeah, actually, it's a big file now. It will not get shared easily.
Ma'am, WhatsApp you can share, ma'am. Bigger files also. On the mail, it might not go.
I don't
But I
have
suggest
it
one
on.
thing. We'll
Yeah.
make Revati to talk in the meanwhile. Let her arrange the slides.
Okay. Actually, I'm able to see. I'm able to see, but the rest of like people are
No,
not
we are
able
not
to.
able to see, Pooja. It is
Yeah, I
not
think
on
we can have Revati
slideshow.
stop first. By the
Full
time this
screen
will be
is not
sorted
there.
out.
Yes, I'm ready.
Okay, I will try to share with Monica ma'am then till that time.
Sure,
Yeah,
ma'am.
please,
I'll
because
just
we have
give you
taken
my
so much
email
of
ID.
effort to make the whole thing. Cannot go waste.
Okay. Okay, I will try
And
to
in the
share it.
meantime,
Okay, then you stop
in the
sharing.
meantime, can I introduce the chairpersons for the next session, ma'am? In the meantime,
Yeah.
Yes.
yes, ma'am. Saiti, can we have the slides, please?
Yes.
Let me take privilege in introducing our chairpersons for the next session, Dr. Uma Devi, madam. She's a senior consultant and laparoscopic surgeon at KIMS Sikandrabad. She's a retired professor at Gandhi Medical College and Gandhi Hospital. Our next chairperson for today, Dr. Archana Dwivedi, madam.
Yeah, hi Monica.
She has been the president of the OGS currently and also the secretary at OGS Dr. today. She has been the president founder of MSW 2019 to 2020, the founder treasurer of Vadodara Menopause chapter. She is also the chairperson of the National Website Committee IMS, Dhira Master Trainer, as well as she is an HPV vaccination champion. We welcome both of you and we request you to please start the next session. Our speaker for today, Dr. Revati ma'am.
Good evening, everyone. I'm Dr. Uma here. Thank you, Monica.
Yes, ma'am.
Thank you, Dr. Monica and Dr. Sneha, ma'am. And thank you for having me here. And I'm going to need to introduce the most learned professor, Dr. Revati Janakiram, ma'am. And she's the director, she was the former director, IOG Chennai, vice president, Foxy, South Zone 2016, the president of Tamil Nadu FOG 2023, founder secretary and past president of Madurai OBC Society, founder president Madurai Menopause Society, journal coordinator for Foxy ACS HPV vaccine drive, recipient of Foxy Dr. Durusha Community Service Award, recipient of Lifetime Achievement Award IMA Madurai, selected as master trainer for PPI UCD program by Foxy Figo. Then the author of Foxy Focus on amniotic fluid A to Z, and contributed many chapters in Foxy Focus issues, and then she for the undergraduate and the postgraduate books. She's a pride of she got the Pride of Foxy Award in November 2019 at Mumbai. Madam, the screen is yours. Please. Madam is going to talk on NCDs and then whether the MHT is useful or not.
Thank you. Thank you very much. Thank you, Dr. Umadevi, for your kind introduction. Good evening, all. First of all, I extend my best wishes to Dr. Sneha for the forthcoming election. And the topic today is the prevention of NCDs. Is MHT an option? Dr. Ambuja has given me this tricky question, and I have to make a justification to give the correct answer. Now, first, let us see, is there any link between menopause and NCDs? Because menopause typically occurs around the age of 50 years, and in the years following menopause, the rate of many chronic conditions like heart disease, stroke, diabetes, dementia, cancer, fractures, all these things increase. Maybe aging is the main cause, but still it's uncertain whether menopause per se is going to contribute to the development of these conditions. Now, although menopausal hormone therapy can help treat the menopausal symptoms, does it help to prevent the development of chronic medical conditions? That needs to be understood. We know estrogen therapy can help decrease the risk of certain health conditions like osteoporosis, heart disease, stroke, dementia, and mood changes. Now, interestingly, it has been found that there is a link between the age of attaining menopause and development of NCDs. Okay. Now, several studies have found that there is a correlation with the age of women starting the menopause. Like in a Chinese study, 2017, when they studied 7,000 odd women, postmenopausal women, they found that the risk of developing type 2 diabetes was 21% higher in women who began the menopause later, that is 53 years or later, 50 years above, than women who started the menopause earlier, that is around 45 to 52. Similarly, they also found that women who began the menopause at a younger age or had a fewer reproductive years, they had a higher risk of cardiovascular disease and stroke than women who began the menopause later. Women who experienced menopause under 43 years of age had a 14% increased risk of cardiovascular disease related death and a 6% higher risk of stroke. And most importantly, women experiencing a spontaneous or iatrogenic menopause before the age of 45 years, and most particularly before 40 years, they are at a higher risk for development of cardiovascular disease and osteoporosis. And they may also have an increased risk of affective disorders and dementia. So it appears that age at which the menopause begins has some association with the risk of development of NCDs. However, correlation need not be necessarily causation also. Now, can we explain the menopause as a cause to increase the risk of developing NCD? Now, the hormonal changes cause variations in the fat distribution in the body. That is, the amount of estrogen decreases and the amount of androgen increases. Now, what happens? The low estrogen and high androgen levels are associated with the menopause. They are associated with 49% increase in the abdominal fat, 22% increase in the subcutaneous fat compared to the premenopausal women. Now, such increased fat content increases the risk of developing obesity, diabetes, and cardiovascular disease. And this is again enhanced by other risk factors, which is associated with aging, including a more sedentary lifestyle and subsequent lowering BMR. Now, the most important million-dollar question. Now, MHT, menopause hormone therapy, is it going to increase or prevent the risk of CVD? Obviously, we know that it improves the menopausal symptoms by counteracting the falling estrogen levels, and it is recommended for that management. And we also know that the WHO study, they have shown, they really stopped, they have terminated the study prematurely in 2002 because of the increased risk of breast cancer diagnosis and also poor cardiovascular outcome. But reanalysis of WHO study resulted in the pendulum swing to a favorable side. There was a paradigm shift in MHT prescription. As we can see in the clinical guidelines of our Indian IMS book, there is a shift from generalization to individualization, from prevention to symptom relief. But even when they say prevention, as of now, maybe circumstances may arise where it may be recommended for prevention also. But here we have some conditions. Definitely there is an indication for prevention. But there is a general agreement that the HT has a favorable risk-benefit ratio in women who initiate treatment between 50 to 59 years and within less than 10 years of menopause. Everyone now is very, very clear about it. The timing of menopause hormone therapy starting. And another thing is that hormone therapy is highly effective, not only for the relief of these vasomotor and urogenital symptoms, they can also prevent bone loss and fracture. This is very important. And symptom relief, again, this vasomotor and urogenital symptom relief provides additional benefits like improved sexual function and increase in the quality of life. Now, what is the impact of bioidentical MST on the risk of NCD? Now, bioidentical menopausal hormone treatment may have a lower risk of non-communicable disease than the regimen which is used in the WHO study, that is non-bioidentical hormones. Now, IMS governing principles on MHT 2016, that is International Menopause Society principle, says that menopause-related complaints like joint and muscle pains, mood swings, sleep disturbances, and sexual dysfunction, including reduced libido may improve during MST. Quality of life and sexual function may also improve. The administration of individualized MST may improve the both sexual activity as well as overall quality of life. Of course, MST must be individualized and tailored according to various factors. After menopause, the probability of developing chronic diseases increase. So prevention is the key, agreed. Menopause transition should be used as an opportunity to visit the healthcare professional for a checkup, assess the potential risks, and proactively start to manage the later life. Obesity, diabetes, cardiovascular disease, osteoporosis, all these things are the key diseases to address. Of course, we have to identify the risk factors, screening, and lifestyle modification. But what about MST in these things? Let us see one by one. Cardiovascular disease prevention in postmenopausal women with MST. Now, if menopausal hormone therapy is being used to manage the menopausal symptom, it may also contribute to prevention of CHD incidentally. Less than 60 years old and within 10 years since transitioning through menopause, the benefits of MST outweigh the risks involved for most healthy women. Initial data from WHO study indicated that there is an increased risk of CHD in women allocated to receive the combined MST. But the treatment was given to asymptomatic women and also years after the onset of menopause, elderly women. But subsequent analysis showed that the use of this combined hormone therapy in younger women or those within 10 years definitely reduced the risk of CHD. And another meta-analysis pooling data from 23 trials also reported that there is a preventive effect of MST if started before atherosclerosis develops. Now, let us see how this MST can help in, as a cardioprotective drug. We know that all of us, we have learned that in women, the cardiac problems are much less compared to men before menopause, but after menopause, it becomes equal to that of men, mainly because of the support given by the estrogen. At menopause, when there is an estrogen deficiency, there is increased risk of atherosclerosis, ischemic heart disease, and angina. And when we give the MST, there is increased HDL, lowering of LDL, cholesterol, and triglycerides also. Now, the impact of estrogen and cardiovascular disease risk is to be understood clearly. Estrogen in MST can have a protective effect in early atherogenesis. This picture is very nice, which depicts that initially it has got a protective effect compared to the harmful effect when it is given in an already established atherosclerosis. What happens in early atherogenesis? It has a beneficial effect by improving the plasma lipids, maintaining endothelial cell integrity, and promoting the nitric oxide production. Conversely, in established atherosclerosis, it can increase the MMP expression, which can lead on to the instability of the fibrous cap and rupture of the atheromatous plate. So, timing of initiation of hormone therapy affects the relation with the coronary risk. There are various levels of evidences, like in women less than 60 years old who are recently menopausal. Definitely, if you initiate this estrogen alone therapy, it reduces the CHD as well as all-cause mortality. And Danish and Finnish studies have also proved the cardioprotective effect. And it is not recommended to initiate MST beyond the age of 60 years solely for the primary prevention of cardiovascular disease. I can quote various studies which have proved the cardioprotective effect of the MST. 71,000 postmenopausal women were studied in the California teacher study, which found reduced risk of for all-cause mortality in younger but not in older postmenopausal women. Again, ELITE study is an RCT to find the effect of oral 1 milligram of 17-beta-estradiol plus vaginal progesterone in two groups, one less than 6 years of menopause and other more than 10 years of menopause. And they have found that there is definitely the change in the coronary intermediate thickness, which is found by the ultrasound. Significant slowing of atherosclerosis in the younger group. Okay. And observational studies, including the nurses' health study, suggested that postmenopausal MST was associated with the reduction of 40 to 50% of the risk of CHD. Codis and colleagues study, again an RCT, found 1 milligram of 17-beta-estradiol daily for 2 years in 222 women with no previous CVD risk. They definitely in them, they reduce the progression of the subclinical atherosclerosis as assessed by intima media thickness. Again, Danish osteoporosis prevention study, the DOP study, which is the longest trial RCT on 1,000 women, which was followed up for up to 16 years, they found 50% reduction in the cardiovascular endpoints. They reduce the risk of the combined endpoint of mortality, myocardial infarction, as well as heart failure. And women in this study were 13 years younger than the WHO study, confirming the timing hypothesis. Recently, in 2022, Harvard in Hardis, in his study has found that he has initiated MST in women less than 60 years of age at or near menopause, and he found that MST significantly reduces all-cause mortality and CVD, whereas the other primary CVD prevention therapies like lipid-lowering therapies fail to do so. And magnitude and type of HRT associated risk, including breast cancer, stroke, venous thromboembolism, all these things are much rare. This is not unique of MST, and it is quite comparable with other medications also. And MST is a sex-specific and time-dependent primary CVD prevention therapy that concomitantly reduces all-cause mortality as well as other age-related diseases with an excellent risk profile. So, keeping in mind that prevention strategies must be personalized, healthcare providers and panelists and patients can use accumulated HRT data in making clinical decisions concerning the chronic disease prevention. Now it's time to recognize that MST reduces all-cause mortality and CVD, and that it is all about the timing. So, having seen all these studies and results, still MST in the prevention of CVD is a matter of debate. As of now, MST is not indicated for primary or secondary prevention of CVD, but at the same time, when given for menopausal symptoms, it doesn't increase the risk. Rather, it has some benefits of preventing CVD, provided correct timing of application is there. Maybe in future, all these studies and some more studies may come to a conclusion, and real recommendation of MST for prevention of CVD may come. Now coming to the bone health, the pivotal role of MST in managing postmenopausal osteoporosis is gaining increased recognition, and it assists postmenopausal women in maintaining the bone health, preventing fractures. Very, very important. Prevention of fractures, the MST is definitely useful, and it significantly reduces the risk of fractures in women, and it is regardless of the bone mineral density. Now, whether this skeletal benefits is going to continue even after the treatment, we are not very sure about it. Not very much of evidence is there. And very, very important thing is that women undergoing premature menopause, irrespective of any cause, MSG must be considered as a means to protect the bone health. Postmenopausal women under 60 looking to protect their bone health might opt to initiate MSG around the onset of menopause or shortly thereafter, rather than waiting until they need specific bone active medications. Historically, there was support for the use of estrogen as a first-line therapy for prevention as well as treatment of bone loss and fractures. WHO, even though it stopped because of the risk of cardiovascular disease in 2002, reanalysis of WHO by age proved the benefits. PEPI study again showed an increase in BMD in hip and spine over 2 years period. And mainly thing is that all these benefits are greatest only if it is started in the early phase, and also significant reduction in the osteoporotic fractures. And it's also seen in the WHO results too. Torgerson et al. Observational studies and meta-analysis also showed significant reduction in all frailty factors. LIFT trial again in 2008 showed 1.25 milligram of tibolone in older postmenopausal, even older women. They found that with osteoporosis, they showed significant reduction in both vertebral as well as non-vertebral fractures. HOPE trial, health osteoporosis progestin estrogen trial, has shown that there is a significant gain from baseline in spine and hip bone mineral density after 2 years. And also it reduces the incidence of both vertebral as well as non-vertebral fractures. Raloxifene, it improves bone mineral density and reduces the vertebral fractures, but not hip fractures. Tibolone prevents both vertebral and non-vertebral fractures. And early menopause require bone loss prevention. And MST is the best rather than the bone-specific treatment. POI, no doubt, it must be offered. And postmenopausal osteoporosis results from a failure to attain peak bone density, accelerated bone mass after bone loss after menopause, age-related bone loss, or a combination of these factors. These are all the reasons why osteoporosis occurs in the postmenopausal women. Now, accelerated postmenopausal bone loss is induced by the estrogen deprivation. So, if you give MST, it can decrease the incidence of all fractures, including vertebral and hip fractures, even in women not at high risk for fracture. So MST is the only therapy available with proven efficacy of fracture reduction in patients with osteopenia. There is no mandatory time limit for duration of MST provided that it is consistent with treatment goals. It is important as the protective effect of MST on BMD declines after, once you stop it, the protective effect may decline. Okay. Although some degree of fracture protection may remain. This combination also, that is another thing, is that TSEC has also been shown to prevent the bone loss associated with menopause, but the effect of fracture reduction has not been explored. Next thing is the osteoarthritis. Now, what about the effect of MST on cartilage? Epidemiological studies of a potential role of estrogen on osteoarthritis showed two very different findings. One is that estrogen deprivation at the menopause seems to be associated with increase in the frequency of knee, hip, and finger osteoarthritis and in the severity of hip osteoarthritis. Second thing is that MST for the menopause may decrease the incidence as well as progression of hip and knee osteoarthritis. So the identification of the estrogen receptors in the normal as well as osteoarthritic cartilage and the effect of this 17-beta estradiol on cartilage in vivo as well as in vitro confirm that the cartilage responds to estrogen. Finally, this response is dose dependent. Physiological doses are protective and higher doses are deleterious. So that point also we have to remember. Now, the lack of established chondroprotective agents limits the clinical management of the disease to relieve the symptoms such as pain and joint stiffness. The WHO study has also demonstrated a 45% reduction in total joint surgery among women taking MST compared to placebo. Although decreases in the risk of osteoarthritis associated with long-term hormone therapy were repeatedly observed in large-scale epidemiological studies, the chondroprotective potential of this therapeutic option has received modest recognition only among the healthcare professionals. So we are not concentrating on this MST as a protection for osteoarthritis. But remember one thing, once osteoarthritis sets in, there is no protection from MST and osteoarthritis takes its own course. Just like this vaginal atrophy. Once the atrophy changes occurs permanently, no point or no use of giving this estrogen therapy. So once it sets in, you have to necessarily go for treatment part depending upon own merits. Now, cognitive decline in postmenopause. Even more than cancer, dementia is the principal health concern in many older adults. But remember, Alzheimer's disease and other things are age-related. It is rare below 60. So obviously, no MST after 60. So no point in talking about that for this. And cancer prevention, with aging, the incidence of all cancers is expected to increase. For women, the most important cancers are breast, colon, endometrial, ovarian, and lung cancer. And remember, use of MST should not be thought of as a strategy to decrease the cancer risk. But some studies have shown that there is a protective effect for colon cancer with MST. The WHO study reported a reduced risk of colorectal cancer in postmenopausal women given this CEE and MPA combination. And other meta-analysis also suggests that MST may reduce the risk of colorectal cancer regardless of the type of estrogen and progesterone used. And metabolic effects of postmenopause by prevention by MST. Weight gain after menopause is primarily age-related, not by menopause, and increased abdominal fat in menopause. That is, it causes increase in the insulin resistance. And contrary to widespread belief, MST is not associated with weight gain and may ameliorate perimenopausal accumulation of abdominal fat. Research has also shown that MST reduces the risk for the development of type 2 diabetes. And a meta-analysis of pooled data from 107 trials concluded that MST reduced the insulin resistance, abdominal obesity, new onset diabetes, lipids, BP, addition molecules, and procoagulant factors in women without diabetes, and also reduced the fasting glucose and insulin resistance in women with diabetes. Obviously, no doubt, POI, premature primary ovarian insufficiency, we have to go for MST. The incidence is 1% of women under the age of 40 and 0.1% in women under the age of 30. And the incidence of iatrogenic POI may be growing because of the increasing survival rates following chemo or radiotherapy. Women with POI are now recognized to be at risk for premature morbidity and mortality because of the various NCDs. And they have impaired endothelial function, ischemic heart disease, ischemic stroke, higher incidence of osteoporotic fracture, impaired cognition, and diminished sexual well-being. So they should receive MST. They usually need higher doses of estrogen compared to women over 40 years of old, and the dose is here. And the aim is to achieve the typical mean serum estradiol levels of approximately 100 microgram ml. And combined estrogen progesterone contraceptive pills may be used continuously until the expected time of menopause. But data from randomized trials of surrogate markers suggest that bone mineralization and metabolic effects are more favorable with MSG compared to cirrhosis. So even POA again, MSG is the preferable choice. And recurrent UTI again, prevention can be with estrogen therapy. It has been shown to decrease the vaginal pH and reverse the microbiological changes that occur in the vagina following menopause. And it is shown to be useful in the prevention of recurrent UTI. So to conclude, possible benefits of MSG in prevention of NCDs: it decreases the risk of type 2 diabetes, decreases the abdominal obesity, protects the osteoarthritis, benefits of verbal memory over the short period when initiated soon after surgical menopause, reduces neovascular macular lesions, and in early menopausal period, it improves the quality of life by its effect on vasomotor, urogenital symptoms, and also by improving the sleep and mood. Areas to explore in future are: number one, effect of transdermal 17-beta estradiol on biochemical markers of CVD in women with more than 2 clinical risk factors for CVD at menopause transition. Effect of 17-beta estradiol and dihydrogesterone on biochemical markers of healthy women and women with CVD risk factors at menopause transition. Effect and tolerability of low-dose CEE and on biochemical markers of osteoporosis at menopause transition. And recently, the estetrol E4, the next generation HD, how it is going to help in prevention of NCDs. So keeping all these things in our mind, to conclude, to put it in short, for prevention of NCDs using MSG, for cardio protection, various studies and evidences are there. Still, we have no recommendation directly to use it either for a primary or secondary prevention. Maybe in future we may get the recommendation. For bone health, definitely it is recommended. Prevention of fracture, it is useful. Osteoarthritis prevention, definitely. And colorectal cancer also, it is very useful. And premature menopause and primary ovarian insufficiency, definitely it has to be given till the age of natural menopause. Thank you very much.
Thank you, ma'am.
Thank you, ma'am. Over to Archana ma'am and Uma ma'am.
Yeah.
Uma
Thank you,
ma'am.
ma'am. It is an honor to chair the session of April, madam, and all the stalwarts over here. I'm audible, right, Monica?
Yeah, Archana.
Yes.
So, yeah.
Welcome,
Yeah.
Archana.
So it's a great thing, madam. I've just landed in Chennai and feeling great to hear you. And with all the stalwarts sitting here, I bowed down with such
You are
a
at Chennai,
good
Archana?
representation of MHP, which is yes,
Archana,
ma'am.
you are at
Just
Chennai?
landed, and I'm
I'm
yes,
also at
madam.
Chennai.
I'm at airport right now. Yeah. So
Nice.
that is why it feels a little more connected, madam, actually. But rightly said that MHT is here to stay. Right patient, right time of giving the MHT at a right route will definitely be a future which is going to help our women, because longevity is increasing, and so are the NCDs going to come in the picture because of the lifestyle modifications which we are facing every day. So thank you for enlightening us so well on various aspects, especially CVD and osteoporosis. Mental health, as you rightly said, that it is just an adjuvant, and POI is, I think, which you highlighted very much, Revati madam, that this is the right patient where the MHT can intervene and help us preventing the complications such as NCDs in the nearing the menopausal age. So thank you, and it's a real honor to see everybody on screen in Chennai, and thank you for enlightening us, ma'am.
Ma'am, I
Sudha
have
ma'am,
Dr.
namaste,
Revati.
namaste, Ambuja ma'am, Ratnavali ma'am, I can see. Yeah.
Dr. Revati, your presentation was very excellent, and Dr. Pushpa.
Thank
And
you.
I just wanted to know, I was not very clear about the osteoarthritis and the therapy, estrogen hormone therapy. So what
Madam,
is
because
the
of the
ultimate thing was that it is not that good effect on prevention of osteoarthritis. Is that the message which you
no,
mean?
madam, definitely it does. Because the estrogen receptors are there in the cartilage, the estrogen deficiency can result in osteoarthritis. So by MST, the osteoarthritis can be prevented. We have to give.
Madam, practically
At what
speaking,
time you want to give it?
Madam?
what time, like, if it is an andropause and all, then can it be used for them also?
No, primary indication for treatment of osteoarthritis, it's not indicated, but
not
it's a
there.
fact that it
Correct.
does. That's all.
Hmm.
It cannot be
Only,
primarily given.
only prevention, very early stages in women. Can I say something, Revati, madam?
Because I was not very clear about it.
Yeah.
So,
I
because
think
sometimes
Revati
that
said
very-
it rightly, madam, that once it is set in, hello, sorry to interrupt. Madam, as Revati madam already said,
Welcome,
once
Dr.
it is set.
And Dr. Shobha. Welcome. Do
Yeah,
live
hi,
and
ma'am.
Thank you.
Actually, the answer to this
I
is
had a
that
very quick question.
Please.
Yeah.
Sneha, good luck for you.
Yeah.
Thank you so much.
Hello.
So I was
All
just
the
mentioning,
blessings.
Sneha
Revati,
ma'am,
madam, I had a
in a
very
young
quick question. Can I go ahead?
Revati, I really appreciate you for the amount of research you have done.
Yeah, that is what Ambuja ma'am, even I was thinking how much madam has read up.
I think none
all
other
studies.
than you would have done so much and presented in
Exactly.
So I really congratulate you.
Thank you. Madam, when you gave this topic, I was just searching. At least I can get one study where I can confidently say that yes, it can be given for prevention.
Yeah.
Madam,
Uma
practically
madam,
speaking-
Uma Devi madam, can I ask, you are the chairperson, can I ask one question? I had
Yes,
one
ma'am. Please
observation.
proceed. Please.
Yeah. So Revati madam, as usual, you read up so much. My God, I'm always in awe of you because I feel you really have a lot of capacity for digging up facts, I just wanted to bring in one fact here that all preventive strategies with using hormones work better when we utilize the window of opportunity in the transitional period, the perimenopause, the perimenopause, those subtle symptoms in a still menstruating woman which we catch, and then we can, and that is where probably in well-suited women, the low-dose combined oral contraceptive pills have immense benefit because they also have, the benefit of prevention of cancers.
So
more than the
Sudha,
MHT.
you wanted to tell something.
Yeah.
Madam, practically speaking,
yes,
so many
Madam.
women who are coming to our clinics, menopausal women, in the window of opportunity. Actually, I gave only for the POI and the women who are symptomatic, menopausal women who are symptomatic, MHT. But all these things, are we, any one of you are using, madam, routinely?
No,
Yeah,
no,
that
there
is
is
the
no
question.
recommendation.
That
There
is
is
the
no
most important.
Those COCs are worth using. Yeah.
There are so many studies
Yes, can
showing these benefits, but unless and otherwise it is given as a recommendation, you cannot give it as a prescription.
Yes,
There are no recommendations.
Thank you, Dr. Ambuja. Dr. Revati, it was a
Madam,
wonderful
can I say something?
presentation,
Just 1 minute. Let Sudha
Hello?
finish.
And very rightly said by Dr. Ambuja that you have, done so much of research in digging out the literature. We all know it. It was all, up to mark with the latest research. I just want to add one thing wherein Dr. Revati has said that estrogen is the only drug which acts on the collagen. You have between the intervertebral disc also you have collagens. You have collagens as far as arthritis, you said in the osteoarthritis. The collagen matter, no drug other than estrogen has an effect on the collagen.
Yeah.
But madam has asked about the prevention of osteoarthritis. Before WHI, FDA had approved all the drugs, estrogens, and that time we used to call it as HRT, for preventive measures of all comorbidities. It was FDA approved. But now, after post WHI follow-up, you do not give any drug for prevention. No prevention for cardiovascular disease, no for osteoarthritis. Yes, of course, when you are giving menopausal hormonal therapy and hormonal replacement therapy in POI, we call HRT in POI. We don't call MHT in POI because POI is a hormone deficiency state. So when we are giving menopausal hormonal therapy, in that window of, a period less than 60 and, nearing postmenopausal, yes, they will get benefit over all the things on the cardiovascular health, on the bone health, on the, osteoarthritis and everything. But per se, if you say that for osteoarthritis, we should give MHT, no, not in any case. Thank you.
Perfect.
I just want
Very
to tell
nicely
one
said.
thing
Not like
before.
a yoga skill.
That is what I wanted to.
Yeah, Archa, before Archana finishes, I just want to tell, after me, I'll give a chance to you, Archana, about the COC use or for POI. Definitely, a lot of research is being done where they don't want to use ethinyl estradiol even for prevention of pregnancy. Then there is no question of using that for the postmenopausal patient because it has got lot of effect on the liver. That is why we are using means because this is a third world country and it is cheap. We are using, but as far as the guidelines goes and norms goes, we should not use ethinyl estradiol for a basic postmenopausal things, and it should be only a natural estrogen until otherwise proved. And second thing is, even they don't want to give ethinyl estradiol for the prevention of pregnancy, and they are trying. That is why it is still an unmet need to find out a pill for that one. That's why alternate things are coming and coming. So I think from now onwards, we should not think of telling COC because so many students answer, we can use COC in the case of premature ovarian insufficiency. I don't agree for that one. And there are so many studies right now. I cannot quote because I did not prepare for that one. But I think it is not a right choice. COC
Next
is not a right
benchmark.
choice for POI.
Ambuja, next benchmark topic.
Archana. The final one is Archana, then we'll move on to the next.
Yeah, thank you for the Sam. The only thing is that I would like to add, Madam has already elaborated that we have to be very vigilant when we are dealing with a patient who comes into the transition phase, even catch them at a very young age. I would prefer advocating annual screening where we can sit and talk, dig out the symptoms and treat them appropriately and guide them at a proper age to prevent the complications. Because MHT, as you rightly said, it has to be indicated. We cannot just empirically give it as a precaution. So thank you for making me a part, and listening to all the discussion was really an honor to me. Thank you, ma'am. Over to Monica.
Yeah, Monica, please.
Thanks to Dr. Ambuja for making me so much.
Monica, you carry on with the next proceedings.
Thank you, Refi ma'am, and thank you, Archana madam and Uma ma'am for chairing this session. I now request Saiti to please share Dr. Pooja's slides so that she can also deliver her talk. Yeah. Dr. Pooja, you will need to command her to change the slides.
Yeah, thank you.
Yeah.
Sorry for the interruption and the technical glitch, but I have this is the another presentation which I made for this today. It was a different one, more focused on GSM, but I'll try to make it up. And we were there next slide, please. That we have already covered that what is aesthetic and functional gynecology. It depends on the exact needs. So it is all about technology. We are now in the 21st century and we have to change and we have to utilize the technology. We don't go by bullock carts now, we go by flights, we cut short our time, we utilize our time and we live a smart living. So we have to change our mindset and we have to use the technologies for dealing with the symptoms of patients and ourselves also. Next. So it is also, I've explained that it is not normal to leak urine after normal delivery because these are the unspoken and unsolved problems. Many people are living with that and accepting it as a part of life, as a part of menopause. So we should not let them suffer. We should have a solution for their silent sufferings. Next slide, please. So laser vaginal rejuvenation, it was a term defined and marketed by David Matlock.
And vaginal rejuvenation or vaginal tightening, we can, it's a umbrella term. It's a proximal and distal part narrowing of vaginal barrel, removing the scarred tissue and reapproximation of levator ani musculature. It's a surgical rejuvenation. And now we are having non-surgical options also. And with that, lasers and RF technology, we can tighten the vaginal barrel and increase the friction and improve the pleasure and orgasmic functions, as well as it repairs the vaginal canal and introitus. It improves the vaginal health index as well. Next slide, please. So in what indications actually we can do all these things? If the patient is having vaginal atrophy, pre or post-menopausal, if she is having any sexual dysfunctions and dryness or recurrent urinary tract infections, or if she is feeling, or her husband is feeling vaginal laxity and stress urinary incontinence is a major chunk. Majority of women having this problem. It affects nearly 19 million women in US. Next slide, please. So we have conducted a survey in, at our start of the clinic, aesthetic and functional gynecology clinic. And in that survey, we found that it was a 48% having moderate to severe SUI. Many people were feeling laxity. It was moderate to loose or light, tight or very tight. And very few were having issues around large labias or rubbing or lugging. Next slide, please. Impact of urinary incontinence and female sexual dysfunctions on quality of life. It is the most detrimental consequence, and we should look into it and provide the therapy as invasive as we can. Thank you. Next slide, please. So vaginal rejuvenation, there are now many studies, and these are the studies which are all demonstrating that it is a very efficacious treatment for vaginal laxity and atrophy, and especially in menopausal women where they are suffering from recurrent UTIs. These are the most common patients we see in OPDs. Next slide, please. These are many studies which are again saying the same things. It is safe, it is effective, and it is well tolerated with a rapid return to activities in daily living. It's a coffee break procedure, and it is a evolving medical field, and many studies are coming up which are backing up. And recently Genital had this study, that TIDE trial also supported that these treatments are safe and they can be used, and more studies are needed. Next. So again, the same thing. Next slide, please. Yeah, these are the different modalities. I'm using radio frequency device, so I'm seeing the results, and they are very safe, and it is improving all the parameters: FSFI score, vaginal laxity score, patient satisfaction. They are increased and higher in the active group. And as we already know, if the patient is having any symptoms, vaginal atrophy or vaginal dryness, then these treatments work as miracle. And it has to be combined with pelvic floor muscle therapy, like physiotherapy, Kegels exercise, high protein diet, then improved and strengthened pelvic floor as compared to only RF or laser therapy. Next slide, please. So these are the various treatment lasers or equipments which are available in the market. These are all like CO2 laser, erbium YAG laser, or radio frequency devices. You can choose whatever you like, and then you can use it in the OPD basis procedure. The monthly schedule is there, once in a month, 3 to 5 weeks apart for 3 sittings. Next slide, please. So everyone has been heard about Great Wall of China, but there is a Great Wall of Vagina in which they have made sculptures of 400 volunteers, that showing that it is normal to have external genitalia. There is a wide spectrum, so there is nothing as a universal normal. So everyone is different, so they should define their normal and increase. They can have treatment if they are having any problem or low self-esteem because of that. Next. So I'm using this machine, Thermi. It has 5 components. Thermi Y is for vaginal wall, smooth, tight, erase, and dry for different modalities. If you have any cosmetic like dermatology or plastic surgeon, we have. So they can use their respective according to the patient's requirements. Next. It's available globally and we can see the results globally. Next. These are different devices. I have tried to compare them, and monopolar RF which I have, it is the most portable one. Other ones are big and heavy, they cannot be portable, and it is safe, and handpiece is disposable. Others are having different like big or small, but the Thermi part is very good because it is having a very sleek probe, and it can be very comfortable for the post-menopausal woman, which is they are having like shrinked vaginal walls and shrinked orifices. Next. So it is very pain-free. There is no pain. It's a 30 minutes procedure. There is no need of anesthesia. There is an effects can last from 9 months to 12 months. And the best part is you can apply it on external parts also. Next. So again, the studies are showing that acceptance is increasing, and with time, there is increased demands. 30% increase. The demand has increased. Next. So it is the machine which we are using, that is called as Thermiva, and it's a monopolar RF based device. It has a range of 35 to 47. Basically, we use 46, 47 degree for vaginal walls, and for external, we use 39 to 40 degree. Next. It is this is the probe, which is disposable probe, and it is just having a very sleek probe, and with a thermistor tip of 1 centimeter rectangle, and ergonomic design, and the temperature I have already. It stimulates the collagenesis without any collateral damage or burn or any side effect. Next. So for the indications are again this: for loose vagina, for loose labia, for dry, for leaky bladder, and for orgasmic problems. Next. And it has been proved by histology also that it improves the vaginal health index, and collagen febrile contractions occur immediately after the treatment and give rise to tissue contractions and thermally mediated wounding, which induces new collagen production. Next. Vaginal stroma is increasing, there is increased blood flow, there is increased signaling, nerve signaling, and it increases the activity of basal layer in labia majora. It increases the maturation of epithelium, presence of glycogen. All the things are improving with this kind of treatments. Next. Mr. Red Alinsod has done a pilot study, and that they have enrolled 23 patients, and they have then applied it on they have marketed this machine then. Next. Next. So how does RF actually works? It is the consistent with subtle connective tissue changes leading to fibroblast stimulation and subsequent collagen replacement and augmentation. Heating of skin and mucosa promotes 3 different kinds of effects, that is immediate contraction of collagen, immediate collagen remodeling and elasticity, and long-term stimulation of production of new collagen. So it is non-ablative device. Unlike ablative devices, they cause the thermal necrosis, and the superficial layer of the skin, they are damaged, and then they produce collagenesis. So this is the milder form, but it is having the effective treatment results as compared to ablative lasers. Next. So again, it is the heat mediated. The energy emission user control to regulate maximum temperature during a time dosage. Next. So it treats all areas of clitoral nerve bundle also, and not just glands. And each shock protein is activated, and the collagenesis is induced. Next. So that's the same, the increasing the angiogenesis, and it restores the nerve signaling. There's a video which is showing the external and internal therapy with this probe. So externally, we can see the results, and there is a gaping or the wrinkling that is gone, and the skin becomes plumpy, and the external appearance becomes very healthy. And then internal treatment on the 360-degree vaginal walls, anterior, posterior, and lateral. If the patient is having SUI, we treat anterior 180-degree more to have to strengthen the urethral walls and to increase the collagenesis and support. So as I've already mentioned, it is 4-5 weeks apart, and the maintenance session we can give after 9 to 12 months. It's a lunchtime procedure, very safe, no downtime, and it's very non-pharmacological, non-steroidal, safe and effective. There is no need of any HRT or as we have already discussed very thoroughly in the last lecture. So it is very safe and no need to take any daily treatment. Next. So I've already mentioned this. They found significant change in 3 sittings. Questionnaires showing measurable changes in FSFI scores, and the changes lasted about 9 to 12 months. Next. This is the score which they have pointed, vaginal laxity score and SSQ score. Next. Next. So you can see obviously over 3 months, the appearance is changed a lot. Next. So you can combine with the O-spot enhancement, a PRP treatment. It improves in female sexual dysfunctions and positive changes in isolated difficulties and reduction in level of sexual distress. So O-spot or O-spot enhancement, this is the term which is used by or patented by like Charles Runnels has patented O-shot. Now we tell it as O-spot enhancement. Next. So it is a global acceptance, and some like in 2013, North American Menopause Society validated energy-based devices for genitourinary symptoms of menopause. It is US FDA approved for some indications, and multi-center trials are going on for this. Next. So in short, it is who will be benefited: SUIs, mild to moderate degree, urgency or mixed incontinence, vaginal relaxation syndrome with natural aging and childbirth, female sexual dysfunctions. It can improve the orgasm, and in genitourinary symptoms of menopause, if patient is having atrophic vaginitis due to any cause, radiation induced or aging changes, recurrent vaginal or urinary tract infections, lichen sclerosis, it's very good effect if it is combined with PRP treatment, anal flatulence or reconstructive surgeries. Next. So again, the same thing, it improves the sexual scores, average 50% reduced time to orgasms. Next. So next. So you can see the early grades of cystocele we can have treated, and the patient is having satisfactory results with recurrent urinary tract infections also and in appearances also. Next. So these are the testimonials which are finding the treatment very useful, and they are recommending to others also. Next. So next. So thank you for this opportunity, and I would like to highlight this, that we should provide solution to silent sufferings and let them live life without leaks and pads. So this is a testimonial from one of my patients that now she can attend marriages and go to market and live my life fully with my partner without any embarrassments. Thank you.
It was a very enlightening talk, and it's really good hope for all patients with SUI at least. You say vaginal rejuvenation, and you show all sorts of posters showing as if it's only for sex, but basically SUI is a very distressing problem, and if there is a solution for it without meshes sometimes come with recurrence and sometimes come with erosion. It can be very distressing. thing. So this is
Yeah.
a no side effect method.
No side
that
effect.
can,
Yeah.
it's
Very
really
nice.
good for SUI, and I think we should it should come up more and more in society, because SUI is there in 50 to 60% of women.
Shobna, I was just interested in knowing the follow-up of women after radio frequency, and how does it compare with the other ones, the laser and carbon
Yeah.
dioxide or PRP,
Yeah.
everything else.
Yeah.
Yeah.
Ma'am, actually, the comparison, there are studies which are comparing CO2 lasers and radio frequencies. Ultimately, the mechanism of action is same. Some are ablative, some are non-ablative.
Yeah,
But
that is
now,
what I understood. Correct.
yeah. So now people are coming up with the hybrid techniques, like they are having a technology mix of diode or RF, because RF is very good for introitus and external area also. Other technologies we cannot do on introitus. So they are combining RF with other technologies and making it hybrid. So it's very good, and I want to highlight that every gynecologist should undergo this procedure, because I have done this on myself first after 2 vaginal deliveries, and then I got it, like I bought it. So I recommend everyone should have like faith. जब आप खुद करोगे, then only you will come to know what it gives and how it affects and improves your vaginal health and all the parameters, not just sexual dysfunction. It improves all the things. See, patients are coming with recurrent UTIs. They have come up with the solutions. Like we go on treating the UTI, but we don't know the cause. Even if we know, we'll give some estrogen gels or supplements, but they have to stop it. But it is like facial. It's a vaginal facial. Means
I think this recurrent
yeah.
urinary tract infection, many of them, they do come and they are put on the long time antibiotics, the urinary
Yeah,
antibiotics.
they have taken all
So-
the sorts of all the antibiotics, but still they are coming again and again, and now we are fed up with what to do. Then that is because we have to treat the cause, and if we don't want to give them HRTs or local gels, we have already given up. This is a long-term effect, like 9 to 12 months. After that there is one maintenance session only, so they can live long life and very healthy and happy life.
Ma'am, you need to unmute yourself. Ambuja, ma'am.
Yes,
Yes, now you're audible, ma'am.
Yeah, am I audible now?
Yes, ma'am.
Yeah, Pooja, Shobna, with your permission, you are the chairperson. See, once I heard from Pooja that she herself undergone the treatment that
Yeah.
made me to select Pooja for this session. And,
Actually, I tell this very proudly, ma'am, because everyone as a gynecologist, as a
second
senior,
thing is,
as a
Pooja,
junior,
what is the cost of your machine?
ma'am, it was around 46 lakhs.
46 lakhs, that small one. Okay.
Because they
And second thing is, most probably, I'm not asking about your station, how much it costs for each session, because it need to be repeated again and again and again. In the beginning, 3 sessions, and every year they have to come back for the session. How much it costs?
Ma'am, it's a cost of disposable now, because I have RF. It's a big cost for disposables, but other machines, they don't have that much cost for disposables. So people are doing it around 15,000 also, 10,000 also, and 25 also. Like in metros, they are doing
Per
it for,
session. Per
yeah,
session.
up to 40 also. I have heard that they're doing a 40 per session. Like it is ranging from 15 to 40,
Thank you,
depends.
Pooja, for bringing out all the new thoughts and
Yeah.
new insights.
And thank you, ma'am, that you have selected me and considered me for this talk. And I really thank you, ma'am.
No, but you explained all the benefits of the instrument, but are there any things which you have come in your clinical practice about any problems which you have faced, not during the time of doing, but post this one, complications or anything?
Ma'am, there is no harm. If someone is not getting a 80 or 90% results, they are getting less results. That's the only thing. There is no harm at all, because that is the cost which is the cost. For what that is the cost? That is the thermistor control. It is very much regulated, and the temperature doesn't go beyond what we have set. So there is no chance of any adverse effect or burn or something like that.
Is there any age limit for that?
No age limit. We have done on
What Pooja told is, when I asked for the long-term complications, he said, "Madam, look at me how I am. I'm enjoying my life now."
Good information for the people who have not seen or.
Yeah, it's a new thing, but we have to try. Like laparoscopy also was new sometime. Now it is like having a very widespread. IVF was also considered as a new thing, and not everyone was accepting it as it now. So long way to go, but now people have at least come to know, and there are workshops, and there is increasing awareness amongst gynecologists that will lead to more and more centers for this.
Thank you, Dr. Pooja. Shobna ma'am, do you want to add something as a chairperson,
I
ma'am?
think you're running out of time, I think. No, you have something more now after this?
No, no.
No, ma'am, you can.
No, as chairperson, I think it is, we have heard this topic many times, but then she has brought out the main things that recurrent UTI. Even today, I had a patient giving D-manose, changing the activities, and they are diabetic and all their nerve ends are gone, and the urgency is such a big problem in these patients, which gives UTI, because of diabetes, the nerve endings are just gone, so they can't control their bladder. So I'm very sure that something should be there to help them.
And it's a very big thing that it is having no contraindication if the patient is diabetic, hypertensive, or
what
any.
about senile 90-95-year-old ladies with urgency? Does it have any help for them?
It will have more effect on mixed, like stress urinary incontinence. It will work the best if it is mild to moderate. In severe also we can do, but it will not like vanish nahi hoga problem, but it will definitely reduce.
You said the collagen improves. So in senile women and senile men or whatever, they are always on diapers, and it's such a big problem holding their urine. So does it hold hope for them also? Not much. Not so far, no studies. That's what you're saying.
For men we don't know, but for females we can do mixing with like for urgency we can give them mirabegron, and then additionally we can do this.
Correct. You
We
can
are all
combine
going
with
to reach to that age, and we're all going to manage women at that age, and this is a harsh reality that 90 plus is going to be a big part of society.
Correct.
We have to learn all this.
Yeah, Shobna, I agree with you. Shobna, if I may, I had just one more question for Pooja. I found that, I have heard many people speak on the subject, but somehow I found her case to be very compelling. I must congratulate you.
Thank you.
You have made a very strong case for the modality of treatment. See, one of the reasons why most surgeons and clinicians don't get impressed when they get exposed to all these techniques is that, while doing the procedure, it is very hard to tell what is the clinical end point, where you are starting, where you are ending, the anatomical details, the clinical endpoints, especially. So it's just looks like one kind of local procedure. And the second thing I wanted to ask you, which is on a more serious note, of course, is what kind of tools you have for assessment in the initial that history taking, and then in the follow-up. I asked you a question of follow-up earlier also, because I find that one should have a validated tool for assessment so that you know how much your procedure has actually succeeded, because it's a little bit, arbitrary sense of improvement. There is no measure like blood pressure or anything which you can say.
It's an upcoming modality. I don't think they can now do it. It will take another 20 years to categorize all that.
Ma'am, there are studies which have like genital hiatus diameter and length, vaginal length, and total, like they have studied also. And we have a questionnaire based vaginal laxity score, urinary incontinence score, and FSFI score. And we definitely see improvements in that up to 5 or 4 to 5 points. Like it improves. So it's a subjective, but there are some studies which are using the objectives like parameters also.
Dr. Pooja, in my opinion,
Yeah.
patient satisfaction itself is retrospectively the endpoint for our procedure.
Yeah.
Complete and satisfied, like you said, you are.
Yeah,
I think
and
that is
they are very happy and they recommend others. That is the end point for my satisfaction and their satisfaction.
Thank you so much, Dr. Pooja ma'am. Thank you, Shobna madam, for sharing this session. Over to Sneha ma'am for your comments and the conclusion, ma'am.
Thank you so much, Monica. In fact, once again, a very good evening to all of you. And thank you so much, Madam Ambuja, for everything, planning, designing the program, and of course, helping me in execution as well. Um, Thanks to Madam Jaideep Malhotra, our chief guest for today's program, and of course, Dr. Hara Patnaik, Dr. Sudha Sharma, and Dr. Jigesh Bhai, who could not join. He messaged me because he was busy in some emergency. But thanks to three of them for accepting the invitation and, of course, gracing the program. Thank you, all the speakers, right from beginning. Jyotika Desai, she set the bar very high. And then, of course, Madam Ambuja took it forward. The talk by Revati Madam was full of research and, lots and lots of analysis. So I'm very happy that we really set the benchmark very high as far as menopause treatment is concerned, menopausal hormone therapy. And of course, Dr. Pooja, she has taken it to the next level. I'm very happy, Dr. Pooja, because you come up with all the advanced management as far as taking care of the symptoms and of course utilizing your advanced newer managements, I would say. Definitely it's going to make people aware of the therapeutics, whatever modalities they are available. And as you said, at least do no harm. That is what is our basic principle. Maybe to start with, for any specialty treatment, it is a challenge, but definitely, as you said, at least it does no harm. So, and of course the treatment, as you said, the patients themselves share with each other with satisfaction. That's going to make mouth to mouth propaganda, and this therapy is going to be established in long term. That is what even my opinion. So thank you so much, covering the entire spectrum of menopause. We can say yes, me, no pause. For me there is no pause. All of us, please, all of us together progress for the betterment of women and women's health. With this note, I thank all of you. And of course, my dear friend, Dr. Monica Ambazat, who has taken this program, very smoothly, flawlessly, along with Sahiti, without any technical glitch. So I thank both of you as well. Thank you so much, everyone. Once again, keep your blessings.
Thank you, Ambuja ma'am, once again.
Thank you, Ambuja ma'am. Thank you, Sneha ma'am. Thank you, Saiti.
Thank you, Monica.
And just,
Thank you many times.
allow me to make an appeal. Yes, I do request all of your blessings and your wholehearted support. Of course, all your votes, not only yours, but your friends, colleagues, alumni, and your relatives, votes who are the eligible voters, because the voting is very close, and I seek all of your blessings. Thank you so much. Thank you.
All the best, Sneha. All the best.
Wishing you all the very best, ma'am. Thank you so much.
Yeah.
Good night, everyone.
Thank you.